Hello, welcome to the fourth hearing of the Committee's inquiry into the equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to Elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the Committee. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome and thank you so much for making the time to give evidence today, especially from interstate. Could you please state your name and position title and swear either the oath or affirmation?
The Executive Director of Operations for SA Ambulance Service.
And could you please swear either the oath or the affirmation?
Sorry. I just lost the... I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you so much, Mr. Lemmer. Would you like to start by making a short opening statement?
Certainly. So I think I want to clarify that the evidence I'm here to give today relates to the mental health co-response team that exists within SA Ambulance. So I think before I start, I just want to confirm that is exactly what it is you're seeking from me.
Yes, absolutely. I'm very interested in the MH Core program.
Certainly. So the MH Core program in SA Ambulance, or SAS, is a paramedic working alongside a community mental health clinician, primarily to respond to low to medium acuity mental health cases. The model was implemented as a way of trying to provide some alternate care pathways and improving some patient outcomes for a cohort of patients that we knew needed access to healthcare, but not necessarily access to an emergency department. As part of this, we've developed a series of referral pathways for the mental health core team, which includes obviously general practitioners, community mental health teams, a mental health triage program, private psychologists and counsellors, support services, as well as an urgent mental health care centre which operates in our central business district and is designed as a walk-in or community referral centre. We have teams based at 3 local health networks. So Adelaide is divided into 3 metropolitan health networks, and we have a team that works within each of those LHNs, responding primarily to patients that exist within their catchment. They generally work an afternoon shift of around 11 or 12 o'clock start for a 12-hour duration, and the teams are equipped, which is then supported by our radio network, mobile data terminal, and obviously the emergency ambulance kits. I think the key piece is to have a really broad inclusion criteria, which is designed really to meet anyone over the age of 18 who is likely to benefit from community-based care. When we first started the program, we had some exclusions which included the first presentation of behavioural emergency or mental illness, and obvious or suspected intoxication or drug use. As the program has evolved and we've become more comfortable with what it is we're delivering, those exclusion criteria have actually sort of been withdrawn, and now really the only 2 exclusion criteria for the team are people who have a suspected medical cause for their deterioration, in which case obviously we want them to go through a different pathway, and those who have an altered GCS as a result of intoxication or drug use. So alcohol or drug use is no longer an exclusion, but obviously if you have an altered GCS and are not able to engage in a community health team, then we won't send this team. I think that's a brief outline of what the team is.
Thank you very much. I'm sure we all have lots of questions for you, trying to understand how this model works and what lessons there are for us here in New South Wales.
Yes.
My first question is about the triage process, and hoping you could elaborate in more detail exactly what happens when someone rings 000 with a mental health emergency. Who's doing that triage and how does it work?
So I think we've sort of expanded and altered the way this is from when we very first put this in. So initially what would happen is it would go through our normal call-taking process. So we have a emergency operations centre that handles all the 000 call volume. They would bring these patients in, assess them, and then make a decision on a priority. If they determined that they needed a lights and sirens response, it would go through to a normal dispatch model and an ambulance would be sent. If they were triaged as a priority 3 or lower, which is not a lights and sirens response in South Australia, then we would have a look at that case and make a secondary assessment as to whether or not it was able to be assessed by MH Core, or a crew may refer to them directly when they're on scene. And we found a lot of our early interactions with this team came from crew requests for how they would be with someone in the community, a mental health consumer, decision that ED was probably not appropriate and seeking access to community mental health teams, and therefore they would tap into this program. What we have seen as the program's evolved, though, is in 2022, much like many other ambulance services around Australia, as we came through COVID, we started to experience back to extreme demand and pressures on our service. And as a result of that, we created what we called a demand management cell to try and assist with that demand and patient support. One of the things we identified during that, though, was what we didn't do well was a clinical review of the mental health events that were pending within the community. So by nature, because they were being assigned a lower priority, they tended to not be a lights and sirens, so no immediate life-threatening need. What was happening is these patients were waiting an extended period of time for an ambulance, and we were identifying that was starting to pose a significant clinical risk for them. So what we have done since then, whilst we had a CTA, so a clinical telephone assessment team, which most services around Australia have in a secondary triage model, that's some way to review those calls. What we didn't have was anyone who had the particular telehealth assessment of mental health. So what we've decided to do to support our MH Core and deal with a broader cohort of these patients is we've actually now introduced what we call a PTC, which is a mental health clinician working within our emergency operations centre. And so what they're doing, and it's a paramedic, so what we have done that is different is historically we've spoken about bringing a mental health clinician from outside of SAS in and working in that environment. And whilst that has been quite useful, what we've found is they don't necessarily understand the environment in which we're operating and some of the complexities that come across in our case when you're sitting from a telephone perspective versus face-to-face. We're finding we're missing a cohort. So what we've done is recruited paramedics who have experience or training in mental health and brought them into the role and are using them now to undertake this first line assessment. So what we're seeing is a lot of the, particularly the threatening suicide type cases, they're engaging quite early, having that conversation and making a decision very early whether they're going to manage via the phone or whether we're going to send our MH Core team in. And then the MH Core team are responding to the case and deciding how to manage that. What we have seen is a significant reduction, a reduction of over an hour in our average response time to that patient cohort now since we've introduced the two.
Thank you. Mr. Lemmer, you may or may not be aware that at the moment in across the majority of New South Wales, there are police leading the response to mental health emergencies. And it's a common concern in the community that if there's a health-led response to those emergencies, that it might put workers at risk. I'm interested in understanding what the safety of staff has been like in the MH Core program, and have you got any data around that?
Yep. So I think one of the things in South Australia that a very clear decision was made was that mental health is a health problem. It's not a police problem. And so we've been really, really clear as a state in trying to say response to mental health consumers should not be SAPOL-led. It should be ambulance-led or health-led. And police come in and support if there is a safety risk, but it's not a primary response. That being said, we do have in South Australia, in the Northern Adelaide Local Health Network, a team of a mental health clinician and a police officer, very similar to the Victorian PACER model. They only operate in the one local health network, and they are primarily dealing with jobs that police are first on scene to, domestic situations, stuff like that, where there's subsequently discovered to be a mental health involvement, and they're using that clinician in that case. But from a SaaS perspective, one of the things we do is we do a quarterly review of all of our data. And so every quarter we publish a report that has a look at the total cases that we attend. So the second quarter's report is out, third quarter hasn't yet been published. So July to September is not quite out yet. But if I talk April to June as an example, the MH core teams did about 700 events through that quarter. About 3/4 of those cases they were able to manage within the community, which means we didn't need to transport to a hospital, we didn't need to bring SAPOL in to help us manage those cases, could manage them quite locally, and most of those were managed with community-based care. There was some referral that went to things like our urgent mental health care centre, which is not a hospital. So it's a consumer-led service with mental health clinicians within it. So it's a different sort of model. With a low representation rate. The bit that is important to us is what we've seen is a very low rate of SAPOL attendance now when we have MH core involved. So we used to have a very high rate in people would pick comments within the case, and challenging behaviours that were identified in the call taking algorithm would lead to a SAPOL response with SATs, and we still have a number of cases that do that. But what we have found is we, by having a mental health clinician within the team, they have access to CBIS, which is our mental health record system, and allows them to make a much more informed risk assessment of the response when we go. And so what we now have is a much better linked up informed response and comfort in dealing with this particular patient cohort. And it's resulted in a much lower rate of SAPOL involvement. And I think what's probably the bit that helps for us is obviously under the Mental Health Act in South Australia, we have a Section 56 where we're able to take a patient into care and control to take them to get medical treatment. What we've actually seen with this trial is MH core have a really, really low need to utilise that. And often when we utilise that, we need to involve SAPOL because it's about, directing a patient to go receive treatment. It's not a detention order. But it is treated in a similar manner in the sense that obviously the patient has no choice but has to be transported to a place of care, often involves SAPOL to take them. What we're seeing is a very low use of that power from this team and able to transport patients in a voluntary manner. And it really is about that de-escalation technique that they're able to use when they're on scene, which means we don't have to bring that third-party agency in to help.
Thank you.
I can send you the quarterly reports if you'd like them.
Yeah, thank you. I'd really love if you'd be willing for us to table those reports as evidence for inquiry. I think that'd be a great interest to the committee. Thank you. And my last question before I go to other members of the committee is I wonder if there's been any work done to look at expanding that model into rural and regional areas, or if you have any suggestions about how we might look at a model like this that would work in the regions.
Like the South Australian geographical context is quite different in, we have quite a narrow band of what we call a metropolitan area that's about 90 kilometres, but quite narrow and bordered by ocean and hill space. And so, our population is obviously nowhere near the size of New South Wales. It also means our regional centres are quite small. And so our work volume within those regional centres is very low. What we do have in some of the towns, so Ceduna, as an example, if you forgive me if you don't know the geography of South Australia, but it's 700 k's from Adelaide. It's over towards the Western Australian border, very remote. So we have what we call a community paramedic that works within that town. So we have a normal paramedic response, and then we have a community paramedic. It's a town that has a very high First Nations population and is often where a lot of First Nations people come from the lands. It's often their first stop from the lands before they make their way into either metropolitan Adelaide or into Port Augusta. So we have a regional paramedic that works out there that is not really an MH core because they have a much broader, they do a lot of primary healthcare and engagement with that cohort of the community. Mental health teams so they can try and help manage these patients prior to them needing to access the health system. And so they do a very proactive get out in the community, and go and meet with them rather than making the patient come to them. They go to a lot of the local community meeting places and do that. So we haven't really looked at the MH core. We don't quite have the work volume to support it in regional SA, but we are trying to look at how we can diversify our response by sort of hybridising components of this role.
Thank you. I think it's really important. So, even in a place as remote as Ceduna, it sounds like in the majority of cases, you actually are getting a paramedic or a health-trained person to those mental health emergencies.
Yes.
Yeah. Fantastic. I'll go to other members of the committee if you've got questions.
I'll go first.
Ms. Duval.
Thank you. Just to continue on and tie off that line of questioning, in the case of the community paramedic, I'm particularly interested in that model. Is it the case that is that's one person? If it is one person, what are their rates of overtime like? We have a particular issue in New South Wales where in our regional areas we have vast amounts of overtime that are sometimes done by regional paramedics.
So I think it's important. So the South Australian context is we have if I talk just regional South Australia, noting that I would consider myself a metropolitan expert, not a regional expert, but regional South Australia is really serviced by both career and volunteer. So career paramedics and volunteer ambulance officers.
So you have volunteer ambulance officers? Yep.
Yes, so we have volunteer ambulance officers, recognising, as I said again, the way our population is spread. So, we will have lots of towns that are serviced by volunteer AOs, and then in regional centres, so, Whyala's, Port Augusta's, Mount Gambier's, they will have career-based teams, Port Lincoln, but then in between Whyala and Port Lincoln, which is a couple of 100 kilometres, there will be Cow volunteers, Lock volunteers, Elliston volunteers that provide a service and are supported by career teams if needed, or by aviation assets from Adelaide, but otherwise manage it like. So the question around overtime is quite difficult because obviously in a volunteer context, that doesn't apply. What we do have though in a town like Ceduna is we have a career-based team that provides the primary ambulance service to the team in Ceduna, and they deal with the 000 volume, whereas the community paramedic tends to, like I said, it is a much more proactive piece. And it's really about that early engagement. And it's a non-traditional ambulance role. It's not, we don't wait for the 000 call to arrive. There's a place in Ceduna where a lot of First Nations people go for breakfast and go for a conversation. And so that community paramedic will often go there in the morning, just take free blood pressures, blood glucose monitoring, and just start this conversation, start talking to people about how they're feeling, and then try and direct them to a community support team if needed prior to that emergency eventuating. So they are really playing in a proactive primary health rather than a traditional emergency response.
I'm interested to know in South Australia if you have a single EMR across the state that helps with this core model.
I'd love to say yes. We are the only ambulance service that still uses paper. So we have a paper-based record. We do have EMR in the emergency record for health in South Australia is still being rolled out. So not all sites are on Sunrise, multiple are. And a complexity in mental health is they run in a separate system called CBIS. So even though their Sunrise record will exist, which is their medical record, electronic, that they will have another electronic system called CBIS that historically only mental health clinicians have had access to. And so that has a far more detailed level of detail regarding the patient's previous presentations. Now, what we have done through this program is we've been able to get access to CBIS for our teams who are working in MH Core, those who are working in PTC and the EOC, and only in the last week we've broadened access to CBIS to try and give it to some of our operational team leaders who are going out and helping manage some of these very complex cases within the community.
So you have access to those mental health patients' details,
yes.
Patient records. Yeah,
yes,
great. In terms of, you've sort of covered off the process of triaging, which I was quite interested in, and how sort of there is an allocation to your service. Was there anything else that you wanted to add to that in terms of when a call comes in, how that's triaged, and then how it's referred on to call that we should know?
So I think we've, again, like every ambulance service, I think we've seen, increase in requests for service or demand on service, and managing in an environment where resources are tight and we have, the eternal hospital flow issue, which results in transfer of care or ramping times that impact. And what that means is that lower acuity case, which unfortunately is where mental health sits, often sits in a pending case. So really the key, we've had this focus on looking for alternate pathways, and we have some really well-developed alternate pathways for traditional medical presentations. What we haven't had is the mental health alternate referral pathway, which is why they've sat and waited. So what the team has given us is that ability, noting that we currently only have them for a 12-hour shift a day, and we only have one MH core team running in each LHN. So it can mean that, some of these cases may be 3 or 4 hours in duration while they deal with it. And because often what we find is it's not necessarily a medical need, obviously they're dealing with, it can be a social need. So they also have access to things like food vouchers, emergency support. And so they've built these linkages with a lot of the other social services that exist, so they can try and help these people stay within the community and then refer them for community-based care, rather than needing to come into a health system. And we know an ED is not the ideal environment in 90% of the time for these people.
Yeah. In terms of your workforce there in South Australia, have they had concerns around this model, or what's been the response?
It's been very well accepted, noting though that because it's low numbers, we don't have issue attracting people into the role, but it's not like we're trying to attract 200 people to undertake the role. There was some apprehension early from people around the concept of working what they view as solo. So whilst they're working with a mental health clinician, there's a lot of confidence in our profession or our sector with working with each other, and people are really comfortable that their partners will understand and read a room, and suddenly having to work with a clinician who comes from a different specialty and hasn't cut their teeth, if you like, working in that true community emergency setting. That led to some apprehension around safety, where that would sit. And so we've put a number of processes in place. We have duress alarms, we have regular contact from EOC and the crew, we have AVL on all our vehicles. So we have a number of processes to make sure we can track. We do risk assessment at the telephone. We have very clear disengagement for them if they turn up and decide that the scene is unsafe. And as those issues have started to go away and people have started to get comfort in the response model that we're providing, what we're now seeing is some increased requests from staff to get access to work on this team. And we're seeing people, though, what we have found interesting is there's a strong push for people to spend a component of time working on this and then a component of time back on a normal ambulance, saying that what they're finding is the paramedic skill set that's enabling them to really support that mental health clinician. And so it's making sure they remain contemporary in their traditional paramedic practice that enables them to work really well with this mental health clinician.
That's an interesting concept. Have there been any incidents where harm's been caused to the workforce in this model?
No. So, and it's one of the things we're really proud of. We do a lot of reporting. So we've had some cases where you would define as a near miss, where a crew have turned up in a highly aggressive, volatile situation. The one thing I say our workforce do very, very well is that ability to walk in a room, pick that very quickly and make a decision whether they need to disengage or not. And so we've had some scenarios like that where we have disengaged, but there hasn't been any physical harm towards the staff involved. We run a safety learning system, so an SLS reporting system where all events are reported, and we run an incident reporting system for acts of violence that are also captured and reported. So we make sure that any of that physical threat are looked at, and we do what we call a high risk. We have a high risk address register, and so if we were to go to a case and experience some physical violence or threats of physical violence, That would come into one of our regional officers who would undertake a review, would link in with SAPOL, link back in with mental health, develop a response plan, and it may mean that we have a particular response plan assigned to an address that says we won't send the MH core team again because of the arrangement, or it might be that we will send them but we will involve SAPOL, and we develop a co-response plan with local police and have an agreed response plan to that particular consumer at that particular address.
And so how do the records that you have access to, obviously this is made a lot easier by having this one record that you're able to have access to, does that record then speak to New South Wales Police as well?
No, so we have, which I'm sure is very similar, we have local liaison groups for mental health that are established within each LHN, and we have an information sharing guideline that applies across government that allows the agencies to share particular information if it's in the interest of safety of the responders or safety of the consumer or person. So we use those ISG guidelines to share information between the parties and agree on a response model. So it may be, there may be a consumer that lives within Northern Adelaide that needs a depot med that mental health will provide, doesn't need an ambulance involvement, but police will go because of a previous history of violence, the police will go and support just a mental health clinician, or it may be a patient who has a history of physical violence, verbal, but can be de-escalated. So we may have what we call a HRA2 plan on it that says we'll attend, police will still come, but we may keep police outside, go in and try and resolve the situation, and if it escalates, police are there to support. It's not now, it sounds great, there are imperfections in all of that, and there are resource challenges for every agency. So lining everyone up at the same time is not without its challenges and can sometimes lead to some of the delayed response, which is really where the PTCs become important for us in the EOC, because they are able to reach in via the phone, have access to all of that record and actually start some of that assessment to make a decision, particularly around the lethality of the suicide. We're concerned that what we don't want is a history of violence, but a person threatening to commit suicide and does not enter the house, only to subsequently enter later and find that they've completed that suicide. So that's the real tricky piece as we try to line up different agencies to respond together, which is why in the north, the concept of having a mental health clinician with SAPOL plus a mental health clinician with SAS, we're finding is sort of ticking both off, because we've now got this really well linked up system where we have two mental health clinicians who work within the same LHN, one working in an ambulance, one working in a police car, that are able to talk to each other and say, actually, we think you need to bring police into this, or able to sit at one that they're at with police and say, we actually think this is a health issue, not a police issue. We want to try and disengage. Can you come in and pick this up?
Thanks. Do you have any others? Or?
Did you have a question? My very last question would just be, have you had any feedback from the community, from the patients that you're serving? How have they found it?
Yeah, so we try to, and again, I'm happy to share, there are some staff surveys and some consumer surveys that we've undertaken to try and understand what that experience is like. As a general rule, what we find is it's very well received, because obviously a lot of it is focused on keeping them out of hospital. So it's about trying to address those needs within the community and finding out where that goes. Obviously, there are a cohort of patients that we end up using a section on and needing to transport, and obviously their experience tends to not be as positive. And it is for us about trying to do that trauma-informed care and trying to remove that. And what we're seeing with MH Core versus our normal ambulance response is that lower use of those powers means that you've got much better engagement from the patient and the consumer in their health care and what is happening, compared to the one that feels that they're losing that control because a normal paramedic crew have responded and said, well, we're going to use a Section 56 and transport you to, essentially, you don't have an option in this treatment path anymore. We're going to take that away and transport you. And we find their paramedic crews tend to use that more frequently on the same cohort of cases than an MH Core obviously do.
Thank you very much. Lenny, last questions with one last minute.
Oh, look, I'll jump in with the last one. In terms of the the MH Core, you mentioned earlier some of the safety mechanisms that are being put in place. I wonder if you're able to provide, perhaps even on notice, what those are and how those were undertaken, and if there is any additional funding or any sort of arrangements in your awards to provide for allowances for these workers in recognition of the skills that they have and the work that they do.
Yes, certainly. So I'm happy to send some stuff over across just to outline the steps. In regards to the remuneration, our enterprise agreement has a particular classification for a single responder. And so whilst acknowledging that they're not a single responder because they're working with a mental health and that classification, which gives them a slightly higher rate of pay than traditional paramedic role would receive working within a normal ambulance, which is really just designed to reflect the fact that some of that operational safety awareness piece, that it is relying on them as an individual rather than both. And probably the biggest challenge we've had in this has actually not been our workforce, because our workforce are quite used to responding to these. It's actually been working with the mental health clinicians, recognising that some of our mental health clinicians are nurses, some of them come from social work and from other specialties, and so getting them comfortable with responding into some of these environments. And they're still in an ambulance. So a really good example is, recently we had a case where we attended a hanging and the mental health clinician was really confronted by that and didn't want to enter because we got confirmation from the scene that they had completed the hanging, and therefore we were going in to respond to cut them down and run a cardiac arrest. And they didn't want to come in. And that piece of that is not an environment that they are comfortable within. Whereas, sounds a bit, but for our workforce, it's sort of the bread and butter piece of what they've come into. So they say, okay. So it's actually that's probably been our biggest challenge in this, in the relationship between and an expectation of risk and safety between our workforce and the mental health clinician. And that, in certain operational areas, our risk tolerance is much higher. In other areas, the mental health clinician's risk tolerance is much higher. And we're just trying to find that happy medium.
Thank you.
Thank you. We're out of time for today. Thank you so much again for providing that evidence from interstate. It's been really valuable. And for those questions on notice or any further questions on notice, the Secretariat will be in contact with you.
Not a problem. Thank you very much.
Thank you.
Welcome. Thank you also for making the time and travelling from interstate today to give evidence. Could you please state your name and position, title, and swear either the oath or the affirmation?
My name is Katie McKenzie. I'm the Executive Director of Mental Health, Justice Health and Alcohol and Drug Services within the Canberra Health Service. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thank you for inviting me.
Thank you. Would you like to start by making a short opening statement?
No, I'm quite happy to move to questions.
That's all right. I will start with a very broad opening question, which is, so one of the terms of reference of this inquiry is looking at alternatives to police for responses to mental health emergencies. I understand that the ACT has a program called PACER, which confusingly is the same name as the New South Wales program, but that is run quite differently from the New South Wales PACER program. Could you give us an overview of what that PACER program looks like in the ACT? How does it work?
Sure, thanks for asking. So our PACER program, obviously PACER is quite a more commonly used acronym now, so Police, Ambulance and Clinician Early Response. Within the ACT, it is a tri-agency response between Canberra Health Services, ACT Ambulance and ACT Policing. So it is a combination of a mental health clinician, a police officer and a paramedic to situations that have been triaged as a mental health crisis. So our PACER response commenced commenced at the end of 2019, and we did a formal evaluation of it this year. So to have a look at our first 3 years of operations and how we can build and strengthen on what it is that we do. And we have shared that report with the Secretariat prior to me coming.
Yeah, wonderful. And of course, we were very interested in some of the really positive results that have come out of that evaluation. I was hoping you could just expand a bit further, because I think this is the critical difference between our jurisdictions, is the role of the police officer within the team in your try response model. Could you clarify that?
Sure. I can give you some broad comments acknowledging that I am here from health, and anything specific about the policing role will need to be directed to ACT Policing.
Of course.
And I'm sure they're happy to answer any questions outside of this forum today. So the role of the police officer, as outlined in the initiation documents for the PACER project, is one of safety. It is of a safety for the PACER team, safety for the person, and of course in line with policing, safety for the community. So as I said, that is their role, and any further information would need to be directed to policing. What I think I can say from our perspective on the health side of it, it's a really critical relationship that we have with police. I think it is under-recognised how important it is to have a collegial and combined response to crisis situations in the community. So for my team, that's the mental health clinicians in the PACER space, they find a lot of value, a lot of support and a lot of reassurance in attending with the police.
And what does that response look like from a patient or a consumer perspective if they've rung 000 and that's been deemed a PACER response? What arrives at their residents in the community?
So it will be 3 people in a vehicle designated for those 3 people. So I think what it might look like is more people coming with a therapeutic intent rather than somebody coming along to take them somewhere that they don't want to, where they want to be taken. But I will acknowledge, if you have read our report, there are some varying points of feedback from our consumers. So of course I am relaying what is a positive point of feedback, is that therapeutic input is critically important to them in de-escalating the situation, and also in allowing the person to be able to remain home and get the immediate support that they need to be able to move from a point of crisis.
And just briefly, sorry, if I can just jump in on that.
Sure.
Just in terms of that vehicle you were talking about, is that an unmarked vehicle, not a police vehicle, not a branded vehicle in terms of what that arrives? Unmarked, yeah.
Yep.
Great, thank you.
That's fine. Look, you've brought it up. It'd be worth exploring some of that consumer feedback further. I know it is in the report that you've tabled.
Is. And I did bring it up because it's very obviously in the report. Yeah. I think some of the... As I've talked about, the positive feedback, some of the feedback that is not so positive has really focused on expectations. Is that when you say it is a mental health response, there is an expectation that potentially there might be more coming than what does come. It is at its core a crisis and assessment response done by a skilled mental health clinician. It does require, for people that need more than that, it requires them to be linked or to follow up at a later time. So there is some differences in expectation. And I think with all emergency diversion programs, there is an inherent tension in what we as the system mark as a success measure, and that is to stay out of the emergency department, versus sometimes the person might have wanted to come into the emergency department. So I think there's tension in how we measure success, and I think that has particularly come across for carers, because if you're a carer in that environment, actually staying out of the emergency department, which is a success for us, is not necessarily what is right for them in that moment. So that is clear in our report, and we've also received that feedback from carers as well, that there might need to be more surrounding a PACER interaction for those times when an emergency department visit is not warranted or needed or in the person's best interest, but equally there might need to be some time of further de-escalation in the home environment.
Could you talk us through in a bit more detail how that triage process works when a person or their carer calls 000? What happens? How does that call end up with PACER?
I'm so sorry. I'm not actually triaging again. It's an ACT policing function. There is a process at which they determine it's a mental health emergency and the PACER team will be dispatched. But outside of that, the detail of that would have to be directed to ACT policing.
No worries.
Apologies for
That's
that.
right. And so I understand the PACER program in the ACT has recently been expanded beyond what it was currently funded for. What was that based on? What
Sure.
were those evaluation criteria?
So when PACER was first set up, it was started as an 8 a.m. to 6 p.m. shift. I think it was even less than that. It was a 40-hour-a-week, weekday response. It very quickly moved into a 10-hour-per-day, 7-day-a-week response. Our second budget uplift allowed the PACER team to be able to bring on an evening team. So the PACER hours of operation now are from 8 a.m. to midnight, 7 days a week. And we are currently exploring whether there is demand for an additional PACER team on top of the 2 that we have in operation.
And has there been any cost benefit analysis of the program?
So the KPMG report does do that. It does outline in saved police time and saved emergency time, and that has to be put alongside the cost of the program. Also, there are a lot of positive benefits that are unable to have a monetary figure put to them. I know that's always a difficult space for Treasury, but for people who do not need to go to the emergency department and we're not seeking that as an outcome, the actual cost of not being re-traumatised, not having to be in a busy environment is immeasurable. So whilst the cold hard dollars are outlined in our evaluation report, I think there is a lot more benefit for the PACER program for the people that have found it very useful for them than what can actually have a dollar figure put to it.
And my last question is about the level of information that the members of that team have about a person when that response is initiated, in terms of police records or medical records. So from the health perspective, what data is accessible to that team?
Sure. So we have a memorandum of understanding about clinical information sharing between our 3 agencies, which outlines that the information that's shared is one that's going to the immediate situation and the circumstances of imminent risk. The sharing of that information is the responsibility of the PACER mental health clinician, and the recording of that is done by all 3 agencies, and the database is maintained by ACT policing. So I think it's good to have those guidelines, and I think in any information sharing context, it is an evolving conversation, and we continue to have it as we learn where other people start to have this evolving conversation. So information sharing is an important part of what we do, but we do need to recognise that there are some boundaries to it, and those boundaries are the situation and imminent risk.
Questions from other members of the committee?
What are the differences, would you say, between your model in ACT and what we have here in New South Wales, particularly any differences that you might see between the 2 health services, whether you have a single EMR, all of those sorts of things?
So I can actually only primarily talk about ACT. So my understanding is that we have a tri-agency response and New South Wales might have a dual agency response. We, being a singular city jurisdiction, listening to my colleague talk before me, we don't have the challenges of having different ways of record keeping through different cities that other states might have. So we have, in the last 12 months, moved to a digital health record. It is not accessible by our colleagues in our other partner agencies, and that is one of the key roles of the PACER mental health clinician, among many key roles that they have, is to access the relevant information from the digital health record and share that as it pertains to that interaction that they're going to.
So I'd be right in saying that you've got one digital health record, but you've also got one local health network, or
We
LHD,
do.
as
Yeah.
we call it, which sounds like a utopia where I'm sitting.
It sounds like a utopia. Sometimes it might not feel like that, but it does absolutely sound like it.
So in terms of the challenges that we would obviously face here in New South Wales with rolling out a similar model, particularly I'm thinking for our regional areas where, we have challenges with staffing which are quite unique. Is it something that is likely transferable, or given the differences between the two that we've just outlined, being that you're one LHD with a wonderful digital health record that everyone in health can access, is it something that would be transferable, or is there a long way to go there?
I think there are principles that could be transferred, and I don't want to downplay the complexity that distance brings to any health service delivery. I think the principles that would be transferable is that it is the role of the mental health clinician to share that information. Again, listening to my colleague before me, our PACER mental health clinician is a senior role. So the reason we have seniority in that role is that they're able to make judgment about what information is or isn't relevant to the situation at hand. And I always think that is supported by very clear and concise memorandums of understanding about information sharing across the agencies. So those things do transcend geography, but I won't back away from the challenges you have in bigger states.
And what are the safety considerations for that workforce? That we heard some of that earlier for South Australia. Are there specific measures that have had to be put in place in ACT? Or
I did, and it was interesting listening to my colleague from one of the other, a far colleague from one of the other partner agencies, Ambulance, speak. He did describe one of the challenges that we have as a mental health service area is that our PACER mental health clinicians are being exposed to situations that they wouldn't ordinarily be exposed to. As he described, real-time incidents that haven't been part of their experience and training to date before they move into the PACER space. And then the other situation that he described, which resonated very strongly as I listened to him, is that we have a multidisciplinary workforce. So a PACER mental health clinician might be a nurse, they might be a social worker, they might be an occupational therapist, or they might be a psychologist. So on top of not having that exposure to various different things that other emergency services do, they come from very varied professional backgrounds with different training to reflect each of their professional backgrounds. So some of the ways that we've overcome that is, so they're all mental health officers, and that does mean that they have an allowance that goes with being part of the PACER team. They're all senior. As you can see from the evaluation report, we've really had to strengthen our approaches to clinical supervision, and we have also had to strengthen our approach to debriefing, and that is a function that's actually taken by ACT Policing to reflect their skill in debriefing of those situations that health wouldn't normally respond to. So, but I will also say there hasn't been, in reference to one of your earlier questions, issues of safety. There hasn't actually been issues of safety. These are longer term psychosocial effects of working in such a raw, fast-paced environment.
for frontline workers, indeed.
Yeah.
In terms of the, so you mentioned they're a mental health officer, which I presume is a classification within one of your industrial agreements.
It's a mental health officer is a classification of the Act, and the allowance that we give to a mental health officer is determined by their industrial agreement, depending on what profession they come from.
Okay, so it's an additional allowance. I'm just trying to think how that would transfer to a setting where we
it's
have
an
obviously
additional
different
allowance.
awards and agreements for.
So if we take it as a tiered approach, seniority, they're a senior role, and they get the allowance on top of that as outlined by their industrial agreement.
And I'd invite you to talk more about particularly the clinical supervision and debriefing. Obviously, you can't speak for ACT Police, which we've previously canvassed, but I'm particularly interested in, their approach to debriefing, which you may or may not be able to provide commentary on?
As I said, I can briefly say we have recognised that it's a very important thing that ACT Policing offer our team. So I'm happy to talk about it from that perspective.
Yes.
What it actually involves would have to be directed to ACT Policing. It's just they have systems and mechanisms for that emergency service debriefing. Ours, for our clinical supervision, we have moved to a space where we have invited a person in on a weekly basis to do a group supervision on top of individual supervision that might be given to individual clinicians if they require it. But that emergency debriefing that happens after a particular incident is very, very important for psychosocial safety for the team. So it's with thanks that I say to ACT Policing that they offer that for our team.
So that's something that's specific to ACT Police. It's not done anywhere else in health but the PACER program.
No, that debriefing is done for PACER. Clinical supervision we have in all parts of my service, but that one is particular to PACER program.
And in terms of that clinical supervision where you're inviting someone in for a group session, is that someone external to health?
External.
How does that work? Someone external to health. Is there clinical supervision that's offered to those that might seek it on a one-on-one basis as well?
So that's determined within our broader service. There is opportunities for clinical supervision, and that would be individual clinical supervision, and that would be determined with their professional lead. So their director of nursing, their director of allied health, or our director of clinical services, who's a medical role. So there is opportunities, but as a broad approach, we offer group supervision throughout the whole mental health division.
The onus is then on the individual if they need to actually ask for it, which
it is for individual
may
supervision.
or may not occur. Yeah. Okay. Thank you. Thanks, Chair.
I had one last question, which is in cases where that very skilled team is a primary response and they actually get there and realise there is a safety risk and then request a secondary response from police, how often has that happened?
So one of the maybe one of the nuances, I'm not entirely sure down to this level of detail for the other states, but one of the nuances in the ACT is that the mental health team, the PACER vehicle may be diverted to other emergencies, and the mental health clinician then may attend other emergencies. So for example, a motor vehicle accident, which is they're attending just because they're part of an emergency response, not because it's a mental health crisis. So how often does that happen? I don't actually have an exact amount. It happens. So in those spaces, it is the role of the police to ensure the safety of our mental health clinician. That role is outlined in our PACER Memorandum of Understanding. Again, for transferability through to other jurisdictions, I think it's really, really important that there is clarity over who has the role of work health and safety in the moment, and that has to sit as well as individually, and each agency also has to have a clearly defined remit at the point of response, and policing do that for us.
Thanks. Any further questions? I don't have further questions. I do note that you've already tabled this really extensive KPMG report for the committee. I suppose I'll offer to you, do you have closing remarks, or are there particular elements of the process that you've gone through that you think would be valuable for us to understand and learn from?
A couple of things that I think reflections from our learning is that PACER is an extremely important response in a robust mental health system, but follow-up is equally as important. Just a brief interaction is never going to be enough for people in crisis. So as you move to thinking about what might work in New South Wales, I encourage you to think of the whole spectrum, not just that immediate response. And the other learning is, as we've got here, is that it's really important to recognise that it is a successful program and move it from a pilot phase into a permanent phase, because that's when you get those good structures around your program that actually at their core support clinicians and the consumer that we're hoping to serve. So, but otherwise I think that's all outlined pretty clearly in our report. So thank you for your interest in what we do.
Thank you so much for travelling all the way from Canberra. We really appreciate it. And if there are further questions on notice, which I'm sure there will be, the Secretariat will be in contact with you.
Contact, or our partner agency is happy to be contacted as well.
Fantastic.
Thanks.
Thank you.
Thank you very
Thank
much.
you.
Welcome. Thank you so much for making the time to give evidence today. Could you each please state your name and position title and swear either the oath or the affirmation?
Yep, so I'm Lawrence Mosqueda, Head of Government Relations at the Black Dog Institute. I solemnly, sincerely and truly declare and affirm that the evidence that I'm now about to give shall be the truth, the whole truth and nothing but the truth.
My name is Nicole Cockayne. I'm the Director of Policy and Research Operations at the Black Dog Institute. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start with an opening statement?
Yeah. Thank you, Chair and members of the committee. We would also like to acknowledge the land on which we meet today, the Gadigal people of the Eora Nation, and their continuing custodianship over this land, and pay respects to elders past, present and emerging. In Australia, we've had more than 50 reviews and inquiries into mental health in the last 10 years. I could talk to you today about all the problems, but I suspect at this point of the inquiry, you probably know all of them. You know that New South Wales spends the least per capita out of all states and territories in Australia, and that it's the only state where per capita spending has decreased in the last decade. You also know that demand for mental health services have never been higher. Psychological distress has almost doubled in the past decade, and there have been steep rises in depression, anxiety, and suicidality, especially with our young people. You also know that in New South Wales, people who need help are struggling to access it. Wait times are longer, co-payments higher, and the mental health workforce are burnt out and leaving their professions en masse, leaving huge vacancies and shortages. You also know the solutions. They've been repeated time and time again during this and other inquiries. We need, first and foremost, funding that meets the burden of disease at a minimum. We have presented you with options on how to find that funding, including a mental health levy, like in Victoria and Queensland. We need funding that is directed towards community-based services with a focus on prevention, postvention, and early intervention. So people not only get treated when they're in point of crisis, but we get them well and help them stay well before the crisis point. This makes economic sense and it's better for people. We need a system that no matter how people try to access care, there should be no wrong door. They should be able to be quickly referred to a service that is right for them and based on the best available evidence. We need data and transparency so that the system, so we know how the system is performing and can improve it over time. But you know all of that. What I want to speak to you about today is the why. Why I'm hopeful that this inquiry will be different. Why I believe that we can not only tinker around the edges, but help fix the mental health system, and why the time is now. The first reason why I'm hopeful is that we now have evidence-based interventions that we know work to prevent and treat common mental illnesses. With the right care, we are achieving long-term recovery rates of up to 80% for depression and anxiety. For the other 20%, which we call treatment-resistant, there are a range of new treatments in the pipeline. For treatment-resistant depression, for example, we at the Black Dog Institute are investigating a range of novel treatments, including ketamine, psychedelic-assisted therapy, and neurostimulation. they're achieving promising results which are pushing the overall recovery rate for depression to upwards of 90%. For anxiety, we are studying new ways of scaling exposure therapies using virtual reality, which are promising results similar to face-to-face treatment, which means we're able to reach more people at lower cost. For PTSD, a condition which used to have a recovery rate of around 40 to 50%, we at the Black Dog Institute's trauma clinic are seeing recovery rates now of 70 to 80% using new treatment modalities. And with new MDMA-assisted therapies, we're looking to push those numbers even higher. We're currently living through a renaissance in mental health science, with breakthroughs happening almost every other month. In Australia, New South Wales is leading, we are at the cutting edge of this research. We should also be at the forefront of its implementation and practice, and that requires investment. The second reason why I'm hopeful is we now have a committed and constructive partner in the Commonwealth Government. Through the leadership and tireless work of Minister Mark Butler and Emma McBride at federal level, we will soon have a roadmap for systemic mental health reform in Australia, which includes reform of the MBS better access system. We at the Black Dog Institute have been working hand in glove with the federal ministers and other leading mental health organisations to deliver an ambitious and comprehensive reform, which will be announced later this year. The Commonwealth Government is moving to close the missing middle, but it needs states like New South Wales to meet it halfway. The time for passing the buck between state and federal governments is over. Now is the time to be working together and finally close the gaps in the mental health system. Lastly, the reason why I'm hopeful is we now have in New South Wales a mental health sector that is organised, mobilised, and ready to stand to support you in systemic reform. Through the New South Wales Mental Health Alliance, established earlier this year, we have brought together the key stakeholders in the state to speak with a unified voice. We invite you to walk this journey with us, to make mental health a priority, and to see New South Wales leading the country in mental health outcomes. Our invitation to you is this: don't let this be another inquiry. Let's do this right. Let's make strong recommendations that will turn into meaningful, systemic reform, and let this be the last inquiry that we will need into mental health in New South Wales. Thank you.
Thank you. Firstly, to commend you on the work you've done through the New South Wales Mental Health Alliance. It's an extraordinary piece of work to bring together some of the most important voices in the sector to have a unified position, and I really commend that. I'm interested in your written submission, you talked about the need for an independent gap analysis,
Yes.
particularly looking at workforce in New South Wales. Is that data not already available? Why do we need to do that?
That is a very good question. So firstly, I think it's a bit of a scandal that we don't have this data available already. I mean, we're talking about some very basic data points, right? We're talking about what's the demand of services broken down by area? What's the current level of service and workforce by these areas to meet that demand? And what's the current vacancy rate broken down by profession and area? We should already be collecting this data, and we should be using it to inform service and workforce planning, but we don't, as you've heard previously. So we've asked for a comprehensive gap analysis, which the Minister has agreed to, and I also thank members of this committee for their advocacy on this. But this shouldn't be a one-off activity. This should be business as usual, right? We should be collecting this data regularly to be monitoring how the system is working, and then improving it over time. And this data should be transparent. It should be made public for both policymakers like you and the sector like us to be able to adjust and make recommendations on how the system should change. I mean, it's also not a new idea. I'd like to take credit for it, but I absolutely cannot. It was actually raised as a recommendation in the 2020 Productivity Commission that all states should publicly be publishing this data, collecting this data, and using the National Mental Health Service Planning Framework to be able to coordinate workforce development nationally.
Thank you. Coming back to your written submission, you've provided some really helpful information about some of the more vulnerable or marginalised populations of specific interest in our terms of reference, and I wanted to particularly discuss people from low socioeconomic background. And I was interested in some of the ways that services are funded actually being prohibitive to people that need them the most, hoping you could expand on that issue and perhaps what your recommendations are so that we can better target services to people who do have the greatest need.
Yeah.
Yeah, thank you for picking up on that. I think that we all know quite well that people from low socioeconomic backgrounds and of low socioeconomic status experience mental ill health at a much higher rate compared to the rest of the population. This actually requires a whole of government response, however. This is not simply a health issue. What we know and what our research has shown us that there are critical issues such as housing, such as homelessness, financial security, education and employment that are all gearing toward why these groups suffer so dramatically different. And I think what we've seen from global data is that, for instance, around 20 to 30% of all suicides are actually driven by unemployment. So it's not necessarily a solution that is focusing on improving mental health services alone. There are broader measures that governments right across the country need to put in place. What we saw during COVID is a really good example of this, where we were very concerned about what would occur as a result of the pandemic itself, the lengthy lockdowns, the loss of employment. The sector as a whole anticipated that we would see mental health suffer dramatically as a result of that. That didn't actually occur, quite fortunately. We saw that suicide rates actually steadied during this period, and what we know from other data elsewhere, from previous similar sorts of crisis where you have put financial supports in place for the most vulnerable people in the community, such as social benefits, welfare payments, that sort of thing, it actually is protective. I think as we go toward what is a deepening cost of living crisis, these are the sorts of things that government needs to be looking at, these broader whole of government supports across social support services, education and welfare more broadly. And so that's what we would be encouraging this committee to look toward as you consider how we can improve outcomes for people from this particular demographic.
Thank you. I have one more question, then I'll go to the committee. I'm interested in your submission with regards to the most appropriate or most effective use of digital technology in telehealth, and I understand there are researchers in Black Dog who are at the forefront of this work. I suppose what recommendations should we be making around using digital tools in a way that will be genuinely helpful?
Yeah, so I think the first thing to say about digital is that there is a lot of evidence that shows that digital solutions can be very effective, almost similar levels of effectiveness and safety within mild and moderate cases of depression and anxiety, which are the most common mental illnesses. Digital has the ability to not only add to the mental health services available, but multiply. So one thing that we've been looking at is not just purely digital tools like apps as a digital therapeutic, but how do we integrate digital into the therapeutic and clinical practice? One way of doing this is what's called blended care. So you might see a clinician, there might be like a 50-50 split. So you might see a clinician 1 week, and then the clinician will prescribe you a digital tool or self-paced module to do in the week in between, and then see you on the week after. So that way, the patient gets extra dosages of treatment. So we're almost doubling the amount of dosage of treatment at far smaller cost. One way that we've been looking at scaling this is looking at how do we reimburse both GPs and other clinicians to both prescribe and monitor these digital tools. That's more of a Commonwealth issue, however. But I think what can be done at state level is really training within the clinical workforce and the mental health workforce about the possibilities and opportunities of using digital tools, and thinking about how they can include digital within their own workflows to both increase patient outcomes and also cost efficiency of their service.
Thanks.
Thanks, Chair. Thanks to you both for appearing today. It's wonderful to see you. And thank you for making such a wonderful submission to our inquiry. It was one that was very interesting to read. I'm wondering, to start off, in terms of our funding for mental health here in New South Wales, there were some interesting statistics within your submission that went to the total burden of disease in that mental health is 13%, but investment into mental health only represents 7%. Is it the case that that figure of 7% should be 13% if we're looking at burden of disease and how much funding? And is that the same that happens with other conditions?
Yeah, so that's the recommendation that we made in our submission, that funding for mental health should be commensurate or proportionate to burden of disease. And as you mentioned, there is quite a wide gap there of it currently being 17% and the burden of disease being 13%. I want to be clear here that it's not always a one-to-one proportion, because of course the proportion of it is to the total health budget, and as we know, the total health budget could and should be more than it is. But the point that we want to make here is that the current level of funding is not meeting the need within the community. It's not meeting the clinical need as well. So that's the lens that we want funding to be looked at. We know that the level of need in the community far surpasses the amount of service that we're giving, such that only half of people that need mental health support actually access it, right? So the need in the community is far bigger. I think one of the reasons why it's lower than it should be is because funding traditionally has been looking at historic service usage, right? And I think that makes sense for a lot of other non-communicable diseases where the prevalence doesn't change dramatically over time. So diabetes, for example, right? Like the pressures around diabetes are diet and exercise, and the population doesn't really change in that way that quickly. However, if you think about the pressures or stresses that determine mental illness, they're a lot quicker. And so, for example, like COVID, right, was a massive stressor on people. The cost of living crisis was a massive stressor on people. Natural disasters have been a massive stressor on people as well. All of these compounded together happen very quickly, and that's why we've including other reasons, that's why we've seen such a huge spike of mental illness in the community, plus also additional awareness. But our system isn't set to be able to work dynamically in that way, if that makes sense. What we do currently is we look at how many people did we treat last year, and then let's see if we can add a little bit more to that. Whereas the demand in the community and the need in the community has increased quickly and steeply, and the funding has not met up with that. And so that's the point that we want to make with burden of disease. It's not an exact measure, but it's a close measure. It's an approximation that we should be aiming for.
If I can just add to that as well, I think that the issue that we face is that the investment should be much broader than what it currently is. There's a real opportunity to invest in prevention and early intervention and to actually divert people away from needing more acute services across the course of their life and their mental health journey. And I think that also it's worth noting that the global burden of disease, I've worked in mental health for about 20 years now, and we always talked about 2025 to 2030 when mental health would surpass every single other disease burden, whether that be cardiovascular disease, cancer, what have you. We're actually there now. It's already upon us. And it's probably the worst thing that we can possibly hand over to the next generation is the fact that we're not doing anything about it. And I think that I would really like for the committee to consider the opportunity to extend the investment in mental health services, but extend that into early intervention and prevention, because that's where you're going to have the biggest bang for buck and improve generations for years to come.
Yeah, it's interesting looking at the graph you've provided, which is on page 10, in terms of the New South Wales recurrent expenditure per capita on services. There's a couple there that are very sort of have plateaued, but there's an interesting data point where specialised psychiatric units or wards in public acute hospitals indeed intersects with and then overtakes community mental health care services, which then sort of plateau. And that point occurred in 2011, 2012. What has been the impacts of that for the rest of the sector? And is it the case that the community mental health care services, which now receive less money per capita than the psychiatric units or wards in public acute hospitals, that needs to now overtake?
I want to be clear that there's sometimes a false dichotomy between community services and acute. Both of them are within the same environment of a shortage, right? Like when the overall spending is less,
it's gone backwards.
It has gone backwards. It's the only one that has gone backwards.
And we're the
out of all this
least spend in the whole of the country.
Exactly. So when you take into account this environment of shortage, right, you've got a scarcity mindset, and you're making decisions with very small resources. And so I understand why in the last 10 years we have been putting more money into acute services, because that's where the crisis point is, right? Like that's where the most extreme and urgent need is. But Nick is right in that the right investment to make is in early intervention and prevention, which happens at the community level. But we have to be doing both. That's why we have to be increasing the overall funding and moving the funding hopefully a little bit more to prevention and early intervention. But I don't want it to be an either-or situation.
No,
we have to be looking at the entire system. And we know that acute services are still in dire need right now, right? Like everything is in very dire need. There aren't enough beds for people to go into inpatient units. There aren't enough of the right beds. So, for example, having juvenile or youth acute beds, a lot of young people are inappropriately being housed in adult wards. We've spoken to multiple people, carers and consumers during this process, where their children are in a ward with adults, and that is absolutely inappropriate and not the right care for young people. So the point that I want to make is it's the overall budget that we should be looking at, and once we have that overall budget, we can start moving more of the investment into community prevention and early intervention.
In terms of the budget that you talk about, I noted with interest your suggestion around how to fund the reform in the way, in terms of a mental health payroll tax surcharge. Yep. And I just wondered, particularly in the light of recent events, the High Court decision regarding the EV tax in Victoria in particular, whether that is actually an option, and what implications that would have.
Yeah, sure. So we put this recommendation together as a way of showing that there is money out there and there are ways of raising revenue, right? This is one of many different revenue raising options, many different ways that the government can find the money for this. The reason why we put this particular one up is because there's a precedent for it. Both Victoria and Queensland have this particular payroll tax, which has raised substantial funds. In Victoria, in the last financial year, I think this tax, this levy, raised $900 million for them in one financial year. To put that in context, overall spending for mental health in New South Wales is like 1.9 billion. So that could be a massive increase, right? So we're not the government of the day, obviously. We're making a recommendation of how you can find funding. But I also want to be clear that like there is always money for things that we prioritize, right? This excuse that there's no money in the budget this time around is not really an excuse. There have been cases where there have been mental or health emergencies, like COVID, for example, right? And we found, 7.5 billion as a response to COVID. Which was the right thing to do. I mean, we can talk about the dollars and cents of it all, but it was the right thing to do at the time. But here in mental health, we're seeing a similar sort of emergency. Suicide is the biggest killer of people under the age of 45. It kills more people than road accidents and skin cancer combined, you know? Like, if this is not a health emergency, I'm not sure what is. So the excuse of saying we don't have enough money is not really an excuse. If we prioritize it, we will be able to find money. And the recommendation that we made is one option for how we could find that money, but there are others.
In terms of the recommendation 10, which also led to savings, I wonder, has there been any work done in modelling an expansion of the HASI or CLS or PCLI program and what those savings would then entail?
Yeah. You want to take that?
I think that there's been an independent evaluation of the HASI program which has shown really positive results. What they have seen is that there's been a decrease of around 10% in people that are accessing services who are in that program. And that's magnified for people that remain in the program for over 12 months. They've also seen hospitalisations decrease by 74% by participants in that program, and so that is huge. Now, that actually is driving quite a cost offset with regard to program provision versus cost to the health system, and the economic analyses that they've done has demonstrated that the per person saving over 5 years is around $86,000. Per person. Now, there were 5,000 people in the initial pilot program. Between, I think it was around 2016 to 2019. So extrapolate that, expand that program, and you would see dramatic savings in delivering a really effective and efficient service.
Do you know offhand what the cost is per person of that program per year?
No, I'm not sure what the cost of that is. That evaluation was done by colleagues from the UNSW at the Social Policy Research Centre, and there is a detailed report that is available that we can provide to the committee.
Thank you. If you could, that would be great. Any more questions? Okay.
Okay. Thank you. And thank you for your submission and for being here today. Just interested in terms of the different outcomes, and we were talking before about the role that different states play when it comes to mental health. But within New South Wales, there's a difference as well, and your submission points out, in terms of regional communities in particular, the different outcomes. And I think you suggest that there needs to be emergency training in terms of mental health when it comes to emergency departments, because that's, I imagine, I don't think your submission necessarily calls this out, but that's the key interface that people may be interacting with the mental health system when it comes to regional and rural communities in particular. Just interested in terms of what your understanding that is occurring in regional and rural communities, and the disparity between mental health support services in the city compared to our regions in New South Wales as well.
I think you're quite right. I don't think that the emergency department is necessarily one of the key points that people can go to in rural, remote, regional areas of New South Wales. It's quite often the only one that's available to them. And unfortunately, the emergency departments are just really ill-equipped to be able to deal with people in crises. It's an area, if anyone's presented to one recently, it's there's constant demands all the time. There's really short triage times that are occurring there. And as you've pointed out, there are staff within there that haven't got mental health training or indeed suicide prevention training. So that is a real opportunity for us to be looking at a very relatively simple and low-cost measure to implement in the rural and regional parts of New South Wales. Black Dog Institute ran one of the largest suicide prevention trials in the Southern Hemisphere over the last 6 years. It was called the Lifespan Trial, and that involved implementing a number of different interventions across a number of different settings in 4 communities in New South Wales. One of the interventions in the settings in particular was in the emergency department itself. So in that instance, we developed a set of guidelines which looked at a whole range of things, but including training for health professionals, and we trained over 900 health professionals from across the state during that period, and that was all in best practice in suicide prevention care. Now, this sort of training already exists. We've demonstrated that it's effective, and that would be a very simple and effective way to address the experiences of people in rural and remote areas. So when they do reach out to the only avenue available to them, they're going to be met by people who are able to adequately care for them.
And in terms of that program, are you seeing, like, in terms of the disparity, and I take it from this discussion as well, it largely falls on the fact that it is in many cases, the only interaction that people are having with mental health providers in emergency. And I think part of your story there effectively is the distress people feel in terms of that triage system and being, you're just sitting there in an emergency department, people would walk away because it's not a broken leg or the like in being seen. But the disparity in particular between the regional experience and the metropolitan experience is because that is the only, or one of the only interactions you can have. Whereas I imagine when it comes to metropolitan emergency departments, there's other services around. So the problem isn't necessarily as significant as what it is in regional communities, but it still would have a benefit in metropolitan areas as well.
Yeah, that's right. And I think that there are a number of initiatives that have already been implemented to a degree across New South Wales that we could look at in expanding them into regional parts of New South Wales to address that issue of having only an emergency department, and they are the safe havens. Now, I understand that you've heard quite a bit about them during this inquiry already. Black Dog Institute is actually involved in evaluating 6 of those sites across New South Wales and the ACT. What we're seeing the study is still underway, but we've got really positive early data that is demonstrating that it's a very effective way to have people present to a very warm and caring and appropriate environment. So we're able to meet people where they are rather than in the chaos of an emergency department. And we're actually seeing economic efficiencies through the data as well as a result of that. So that information will come to be available over the course of the next 6 to 12 months, but it's very promising in early days, and that would be a very reasonable and sensible approach for New South Wales to take in looking at expanding the existing services such as safe havens in rural areas of New South Wales, but looking at your data and understanding where these are actually needed and expanding the program itself to be in more community regions because they are effective and they do work.
Thank you.
I had one last question. In your written submission, you cited the very distressing statistic that 23% of people discharged from a mental health hospital do not receive follow-up from a community mental health service, and that was from the Productivity Commission. You've cited that as part of your recommendation for a statewide community mental health navigation support service, which has been touched on in other evidence as well. I'm interested in understanding how that model might look, who might be running that service.
Yeah. I think that the problem that we face in New South Wales, which is right across the country really, is the difficulty in how fragmented the various services are and how complex they are. And they're not integrated and they're terribly misunderstood in terms of what's available to you. And the irony is that somebody in distress actually is, they're not functioning in their usual state. So they're not able to comprehend information that's available to them. They're not able to make decisions as readily. And so what we have available at the moment typically is a service directory, if you like, that people can log into or call a phone line to find out about, but it's not tailored to their needs. It's not meeting them where they are. And it's simply not meeting a need. So what we think could occur as an alternative to that is having a service, a support service, where you have that warm and friendly concierge type of approach, where somebody is there to support you, to understand where you're at, to understand and guide you toward the services that are appropriate to your own local area, whether that be a bricks and mortar kind of service or a digital service that you can access, whatever it might be. And typically, I think that we've seen through work of the New South Wales Mental Health Commission, through their peer support project, that these could actually be served by peer support workers. So we don't necessarily need mental health clinicians to do this. They bring a level of empathy and understanding from their own experience of service utilisation. So we'd actually suggest that the peer navigation project from the New South Wales Mental Health Commission should be the grounding for which we could look at how this could operate. We know that the Way Ahead service also has a very similar type of program where they're directing consumers toward the right treatments, the right services at the right time. I think critically, in order to address the accessibility issue, the peer support worker is paramount, but also providing a digital gateway for this is really important as well. Where we've seen digital gateways established in mental health and in other areas before, which haven't been successful, it's usually because they're not designed in a way that promotes an ease of use. So we really need a human-centred approach to how these would be developed and then implemented. But there are certainly foundational programs and pilot projects in the state that we could look at and adapt in providing such a navigation service.
Just in that final bit of your answer there, you mentioned existing pilots in this state. Is that something you'd be able to provide more information about on notice? Do you have access to that?
Some of those reports are publicly available, yes, so we can provide those to you.
Fantastic, thank you. We've got 1 minute left. If there's no further questions from the committee, do you have any closing remarks or anything else you wanted to point out to us?
No. I think we've covered everything.
Yeah.
Thank you so much for having us.
Thank you so much again for the time you've taken to present today, and also for preparing a really excellent written submission. It's much appreciated.
Thank you very much.
Thank you.
Thank you.
Thanks.
Thank you.
And for those in the gallery and watching on the live stream, we'll now be breaking for lunch until 1:30. Thanks very much to our next witnesses from Headspace for making the time to give evidence today. Could you please each state your name and position title and then swear either the oath or the affirmation?
Yes, my name's Simon Dodd. I'm the Head of Workforce Planning and Development at Headspace National.
Hi, my name is Annie Hong, and I am a member of the Headspace Youth National Reference Group.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. And just for your information, I know the room feels a little bit empty today. We do have a couple of our committee members who are tuning in via WebEx on the screen in front of you. Would you like to start by making an opening statement?
Yes, thank you. First, I'd like to acknowledge that we're on Aboriginal land today and acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the land in which the Parliament of New South Wales stands, and to pay respects to elders past, present and emerging. I also would like to acknowledge people with lived experience of mental illness and their valued contribution in building and reforming mental health services and systems. We thank the committee for holding such an important inquiry and providing the opportunity to give evidence today. We're here representing Headspace National Mental Health Youth Foundation and the young people, centre staff and lead agencies who comprise our network of centres and services across New South Wales. In our submission, we highlighted that young people need accessible and holistic services to meet their mental health needs, that building the youth mental health workforce is critical, and that there is a growing need and focus on providing integrated services and supports for young people. I'd like to invite Annie to offer a brief perspective of these issues as our opening remarks.
Good afternoon, Chair and committee members. Thank you for inviting me here today. My name is Annie, and as I said, I'm a member of the Headspace Youth National Reference Group. This is a group that works with Headspace to ensure that young people's voices and opinions are at the front and centre of all the initiatives and the resource allocation that Headspace does. But outside of this position, I'm also a 23-year-old university student studying psychology and law at the University of Sydney. And I'm here today to share my lived experiences about my experience through the mental health system. Briefly, late last year was a particularly difficult time for me, leading me to seek help and go to Headspace Camperdown to get a mental health plan for the first time, and also to seek help from a psychologist. Despite my studies, navigating the system was eye-opening, to say the least, revealing the challenges of the cost as well as the wait times. I saw how these factors, in addition to the quality of care, really shape and influence how a young person perceives the system as a whole, as well as their general well-being and the way they perceive or the way they seek future help in the future. Today I speak only my experience, but we know that more young people struggle with rates of mental ill health than any other age group. 3/4 of mental health issues emerge before the age of 25, and more young people die from suicide than from anything else, and the statistic is 40%. But getting help isn't easy. If a young person works to overcome the stigma associated with seeking help, they are faced with additional barriers, like I've mentioned, such as wait time and cost. When we have the courage to seek help, we need services that we trust and are easy to access. We need to know that we are unlikely to be turned away and that we will feel welcome. Youth mental health services should be youth-focused, designed with young people, for young people. We are the experts in our own lives, and we want to be actively engaged in the whole process. It shows that we are trusted and respected, and helps ensure services are credible, approachable, relevant, and credible. Thank you.
Thank you very much. And we'll now go to questions from committee members, perhaps starting with Mrs. Carter.
Sure. Thank you both for being here today, and thank you for your opening statement, and thank you for your submission. I noticed that you've been working in the space since 2006. I wonder if you could give the committee a sense of what might have changed since 2006.
I might take that one, Annie, because I don't know whether you were old enough to have worked for us at that time. In 2006, we started with 10 centres. We now have 154 centres across Australia. And obviously, the landscape in terms of the delivery of service with those resources is massively changed. There's 45 centres services in New South Wales, and there was another 6 that are being planned in the next few years. The young people's needs have increased in that time. I think very clearly there's quite a lot of evidence that you've already received about the increased demand from young people, which is an interesting thing. And there's also, I think, probably our capacity to deliver services to those young people has, even though we've increased the number of services offered, we have a reduced amount of capacity in many ways to support young people and their families at the same time.
Sorry, can you just explain that? Why, if services have increased, has capacity to deliver services decreased?
So I mean, I think in the whole services being able to deliver have obviously increased. However, if we look at the MBS percentage of services offered by Headspace, which is a bulk billing entity, the MBS services 5 years ago in New South Wales, about 48% of our occasions of service were delivered through the MBS, and now that's around about 18%. So that's what I mean by the decrease. So although there's been an increase in our capacity to, in total, offer services through the funding that's resulted in Headspace, we've seen an increase in demand such that it's been difficult to keep up with it. I think that's what we mean. Yeah.
And the demand is because we've got a higher rate of mental illness and mental distress, or it's because we've got a more educated population who understand when they need to seek help and are seeking help at earlier and more appropriate times? Any sense of which one of those it is?
I think it's all of those. I think we, in the 2022 National Youth Survey that we did, which has a fairly significant cohort in the tens of thousands, we found that young people had a higher rate of high to very high levels of distress compared to the previous time we'd done that, which was about 3 years before. And distress is a good indicator, a proxy of either existing mental ill health or emerging mental ill health. I think that there are significantly increased levels of natural disasters and the impact of the response to COVID has significantly impacted young people, but also climate change, concerns about climate change, and also the trauma and future concerns and cost of living issues are all issues that young people talk about. But I think, Annie, do you want to add to that?
Yeah, sure. I think in addition to what Simon talked about, a lot of my peers are more open about their mental health, and that's not to say that's the same for everyone, but I think there's a more encouragement from people to speak out, and so that's why there might be an increase in demand. But there's also the increase in pressure of social media that has really taken a hit on young people, such as TikTok and Instagram, and all those are factors. There's sort of a dual message behind those. On those platforms, there's a lot of calls that you can seek mental health, but at the same time, it's also perpetuating a lot of standards that might lead to a lot of mental health problems.
Okay, that's really interesting. So if we were looking at shaping recommendations, should we be looking at recommendations that might shape or limit the way social media can be used if it's a harmful influence?
Well, I'm sure Annie's got some thoughts on that. I mean, I think social media is a complicated beast. That it absolutely provides benefits to young people in forms of connection and supports, but of course it's an avenue for distress and there's well documented multiple concerns around bullying and access to people after hours. So, one of the main differences between now and 15 years ago is that if there was problems at school, those problems often follow a young person home, and so that makes it very difficult to get any relief from that.
Yeah, and I completely echo what you mentioned about the benefits of social media. I think from my perspective, it's people need to understand boundaries related to social media use and know how to manage and when to shut off from that platform. I think a lot of people subconsciously turn on social media as the first thing, and it's often you don't really feel the impacts of it until you've hit like a sort of a breaking in where you think, oh, perhaps I should limit my use. But perhaps if there was more education around that platform as well as ways to manage it, that would be quite helpful.
So an education campaign rather than a set of regulations, perhaps?
I think it's difficult to regulate the space, and perhaps it's easier to make informed choices for young people about when they can best manage the use of social media for themselves.
Okay, thank you. I notice in your submission that there's quite a lot of reference to drug and alcohol, and I just wondered the extent to which drug and alcohol feeds into mental health issues for young people, or the extent to which it's self-medication of undiagnosed mental health issues. If you have any commentary around the interaction between drug use and mental health issues.
So so substance use and alcohol or other drug use is a complex area, and certainly some young people use it to manage the level of distress. It rarely exists in isolation, and it often regularly coexists with either an emerging or an existing mental health difficulty. So does it lead to mental health difficulties? That's one of the always questions that we're asked, but certainly it usually exists co-occurring.
So you would perhaps recommend, or it would be appropriate for us to think about, if a young person is in contact with the police because of drug possession, it might be appropriate for an automatic mental health referral for investigation?
I think that's a very that sounds like a great idea, but the detail would really need to be explored to see whether it would work. Diversion programs are there's lots of evidence of the benefits of diversion programs, and as I said, substance use is complex. People use substances for different reasons.
But wouldn't a mental health examination be part of a typical drug diversion?
Yeah, it absolutely could be, yes.
Yeah, so you don't have any experience with drug diversion programs or mental health and AOD interaction?
So Headspace is a holistic program and has four core streams: mental health, alcohol and other drug, work and study, and physical and sexual health. So our services absolutely have an ability to support young people with AOD services, and the reason why they're bundled together, those four core streams, is because young people present how they present, and we have an obligation to provide the services that they require. Most people who come to Headspace centres come for mental health difficulties, and alcohol and other drug use is a much smaller percentage. But I strongly think that that a young person should have access to whichever services they require, and that AOD services are well placed with mental health services and not in isolation. Isolated services and siloing of services is a problem for access.
I guess that's what I was trying to explore, the relationship between the two and the way in which whether they're related or not.
Yeah, I think they can be related, but not necessarily. And I think that each young person is different, and their exposure to services should be related to what they need. But AOD services are should be part of that solution, as should be physical and sexual health and work and study services.
Well, that's your model, isn't it?
Yes, that's exactly right. That's why the model exists as it does, and we stand by it.
I'll go to Ms. Siva.
Thanks, Chair. Thank you to you both for appearing today. My first question is probably best directed at Mr. Dodd in your capacity. Given you've a national framework in governance, but your licensing is done at the national level, and then you've got funding through the local PHNs. How do you manage that? Those competing interests, some would say even a conflict at the local level in terms of what you're able to implement.
So, could you?
You've got a national framework and
Yes.
governance structure, but you're funded through local PHNs, and local PHNs may have their own recommendations about how you deliver care. How do you manage that conflict?
So PHNs are funded via federal government for the commissioning of headspace centres and the funding of them, and
Yes.
our role is as in terms of the fidelity of the headspace model, and we do that in a variety of ways. We have a model fidelity framework that we undertake each 3 years for every centre, which is a very involved program to ensure that the centres are aligned to our structure. And we also have an escalation process from centres to the National Office around critical incidents. However, the clinical governance and the day-to-day governance sits with the lead agencies, and they report to the primary health networks in terms of their activities. How do we implement things? We implement things usually through funding opportunities. So, for example, the New South Wales Recovery Program that was implemented through following the COVID funding, there was an expression of interest offered to centres that were eligible, and the eligibility was related to their maturity as a centre. Following this expression of interest, there was an allocation of funds for them to ensure that they to allow them to do the activity, and then that was contracted, and we ensured that they were compliant with the activity deliverables through the contracting process. So that's an example of one of the processes where we hold the governance, whereas if the primary health networks have funding through the federal government for other activities, then that sits with the primary health network in terms of their governance.
My understanding is the primary health networks fund the centres, which
Yes.
is an intentional decision to meet that sort of local need, and then that funding is obviously dispersed to the lead agencies. And what some people may not know is that obviously you've got different lead agencies delivering different headspaces. So how do you ensure the delivery of care is of a standard if you've got different lead agencies, you've got several levels within that?
Yeah, so exactly that's what the fidelity model is aimed at doing. It is very challenging because there's a responsibility. I think it's multiple layers. That the commissioning process includes Headspace National, and so there's an opportunity to ensure that the lead agency is an appropriate lead agency to perform the tasks, and there's heavy involvement from National Office staff in assisting the lead agency to set up the program, there's a number of lead agencies with multiple centres, and obviously they're well placed to deliver services with the experience they've had in delivering it elsewhere. And then we have ongoing contact with them to ensure that they meet the minimum requirements for service delivery and service.
Understood. So given you've got the national framework, which is very clear, is consistent across all headspace centres, and then you've got then you've got the PHNs at the next level, and then you've got the lead agencies. How is it that we're making sure that what the PHNs are recommending to the lead agencies is in fact best practice, and what the community needs at that bottom level when they've got to fit in with that framework at the top? Is there a conflict there, and how is that resolved?
Yeah, I mean, I certainly think there's a challenge for the lead agencies who as the centre representatives in having two masters.
Yep.
And that's resolved through discussions with the primary health network and Headspace National. But it is aligned with the government's guidance, the federal government's guidance around the activities that are undertaken by the centres. But it is a challenge. It's absolutely a challenge, yes.
And with these, the model fidelity framework that you mentioned and that sort of auditing measure that's in place, it's my understanding that there are several headspaces that struggle to pass that auditing system. Is that the case?
Centres are placed in a process whereby they may not yet meet the requirements, And so there's a coaching and support process by which we endeavour to get that centre over the line in order to be able to meet the minimum requirements.
I might ask if you could provide on notice for the committee, certainly for New South Wales, what those results are across New South Wales, because I think that would be certainly very interesting in terms of making sure we ensure the regional aspect in particular is met. I've just got one or two last questions before I finish up. I'm just mindful of time. Just wanted to confirm that all your centres are free of charge.
So, effectively, yes. The centres, we have a low or no cost. I'm not aware of any centre that doesn't bulk bill when there's MBS funding.
A low or no cost.
That's
so there
right.
may be some that charge a fee?
That is part of our charter, but there is, to my knowledge, there's no centre that charges a fee.
Are you happy to provide it to take on notice? Because my understanding is that's not the case. We'd be very interested to find out if there were centres that were now charging fees.
Yeah, my understanding there is no centres, but I will take that on notice.
Thank you. In terms of the existing rural headspaces that are open, are these an appropriate model and are these effective? As it's my understanding, again, that some of these rural headspaces are only open a couple of days and are not sufficiently staffed.
So there a centre and a satellite and an outpost are different models. So satellites, which sit under the governance of a centre that's regionally connected, has the same lead agency nearly always. And that has a minimum days open of 3 days a week and must offer 3 of the 4 core streams, including mental health. As that's a satellite, and they would be open 3 days a week. But all centres must be open 5 days a week. If they're not open, then that's a notification to the National Office for a please explain and process. I think there are 22 or 23 centres or services in non-metro areas out of the 45 in New South Wales, and they are, as across a large number of services, they vary in their capacity to deliver services depending on one of the main things all services in the sector are having to deal with is the mental health workforce. So we really, really struggle to get staff, to get clinical staff and all staff. And that's the single biggest rate limiter on our ability to deliver service.
I have further questions, but I'm just.
Can I get one, and then we'll come back to you?
Yep.
I firstly just wanted to acknowledge the extraordinary reputation of Headspace to provide cultural safety for young people, and that's no doubt informed by the fact that you've got a youth reference group, and it's really wonderful to see you here today, Ms. Hong. My question is about the question of continuity of care. I understand that the core business of Headspace from a mental health perspective is lower acuity mental health presentations, and we've heard from young people some of the challenges where they might have a known counsellor or support worker through a Headspace who then is forced to refer them to another service when their condition becomes more serious and they feel sort of bounced around between services. I'm interested in what work either is being done or that needs to be done to better enable that continuity of care for a young person when a Headspace might not have the full scope of services that they need within a centre.
Yes, I think, and I'm conscious I'm answering a lot of the questions, Annie, so jump in any time. But I think this talks to the missing middle effectively in some ways, where we have the so-called missing middle, where we have a higher level of complexity or severity than the original charter of Headspace, which was mild to moderate early intervention. It's much more common to see moderate to somewhat severe than it certainly was, and that's a significant difference, I think, also in terms of how things were 15 years ago when we started to now. The best practice is continuity of care, absolutely, in a multidisciplinary team, and including a shared care process, where that includes tertiary services, where the therapy is delivered by Headspace, where it's delivered through salaried staff, there's very few salaried staff in centres, as you'd know. Then there's potentially greater capacity to hold that shared care. When it's held through MBS funding and through a mental health care plan, then there's challenges in that system in terms of shared care as well. So in some ways there's complexities in how you can do that, but we absolutely acknowledge that shared care and continuity care is best practice, and we endeavour to ensure that best practice occurs at every occasion. I'm sorry, I don't know whether I answered your question there, Chair.
I think you spoke very well to some of the challenges. I guess, from the point of view of Parliament and making recommendations in this space, I'm interested in what needs to be done to potentially enable better continuity in those scenarios.
I mean, one of the things that the New South Wales recovery funding allowed us to do was to trial some work in centres that we've been wanting to do for a long time around GP practice. So GPs in headspace centres typically are seeing people who have a higher level of complexity and severity than the centre would normally be able to manage, in alignment with the therapy that they're receiving by the counsellors, and particularly when they have access to psychiatry through secondary consultation or consultation, then they're able to hold a much higher level of severity. So about 10,000 occasions of service occurred through this 18-month period by GP and GP-supported services. That includes practice nurses and nurse practitioners in centres through the same funding. And that, although those occasions of service doesn't sound many, it is equivalent to about 3 centres worth of services in a year. So 10,000. The level and the quality of those contacts are different. They're higher levels of complexity. In the same program, about 1,000 occasions of service were held by psychiatrists, and obviously the services that they're offering have a much higher level of complexity and severity than we would normally be able to manage in headspace centres. So I speak to this because that allows for continuity of care and able to hold someone in a headspace centre rather than referring to tertiary services. And I think that's what some of the bilateral funding for where LHDs are offering resources into headspace centres that's co-funded by the federal and the state governments, is looking to try and emulate that. And we've had, I think we could say we've had good success with those models, but the GP component isn't part of that bilateral funding likely. And I think it's certainly something that we would love to explore. We think GPs are essential to headspace services, but unfortunately it's very difficult because they're primarily funded through MBS to get them into centres beyond more than a day or so a week in most centres. So I think we've got about only 9 of our regional centres have GPs in them of the 22, for example.
And just to clarify, I'm really interested in this work. I think it does sound like a useful model to embed GPs and psychiatrists into the service to enable that continuity. Yep. You said recovery funding. Are you referring to the COVID-19 recovery funding?
Yes.
So you were only able to properly embed GPs in Headspace because of COVID funding?
What it allowed us to do was to fund the GPs in a salaried model. And I think Dr. Vagona spoke to this earlier in the proceedings, and it's quite something we've been interested in doing, but it's very difficult to find that funding. So this allowed us to trial that and trial it successfully, I think.
Yeah. And when did that funding run out, or when does it run out?
At the moment, we're in discussions with the government. At the moment, it finishes in June of next year.
Thank you. Sorry, there's only 2 minutes left, but
no, that's
back
fine.
to you, Ms. Hill.
My question was around, it sort of leads into that nicely, around the staffing component. You mentioned earlier having some challenges with attracting and retaining staff. Is it the case that that is more so felt in Headspace, and if so, why, and what suggestions do you have?
I think this is
around your funding model. Like, I'm just, how are your staffing positions funded? Would it make sense, or would it be more effective if you could attract people to permanent positions when you're competing with the private market and all of those other things?
Yes, it would make a lot of sense to have ongoing salaried positions with multiple year contracts. Absolutely. There's challenges with getting private providers. in Headspace centres, as I've said. That's not New South Wales, that's nationally. And our biggest competition is actually not private providers, it's actually the state government services.
So what is the difference between the salary and the arrangements between the two? The moment you can't provide a salary to your staff, it's just based on occasions of service?
So we have some salaried staff in the centres, and the model was originally structured to have some salaried staff, but the predominant therapy would be through private providers through MBS. As we have reduced the number of MBS providers in the network, then those delivery of therapy services has sat with the salaried staff.
Okay.
Yeah.
Interesting. Yep. Thanks. We've run out of time.
We have run out of time.
Yep.
Thank you so much again to both of you for making the time to give evidence today, and also for your detailed submission. And the Secretary will be in touch with you with any questions on notice.
Thank you very much.
Thank you.
Can you hear me all right on WebEx?
Yes.
Wonderful. Thank you for making the time to give evidence today. Could you please state your name and position title and swear either the oath or the affirmation?
Nicola Rabbit, School Wellbeing Nurse in Cooma. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Would you like to start by making an opening statement?
Yes, please. Thank you. First of all, I would also like to acknowledge the traditional owners of the lands on which we meet today and pay my respects to elders past, present and emerging. Good afternoon, Chair, Deputy Chair and committee members. Thank you for the opportunity to speak to this mental health inquiry. I'm here today only in my capacity as a wellbeing nurse in Cooma. Working for Southern New South Wales Local Health District, I am part of a wider New South Wales Wellbeing Nurse in Schools program. I can only speak to my experience working in Southern LHD, and I will shorten my reference to this program to the WIN program. I began working in this program in 2018 as a nurse in schools pilot in Cooma, funded by Snowy Hydro initially and then evaluated and funded by New South Wales Health from 2020, expanded to 6 and now to 100 nurses across vulnerable communities in New South Wales. We work in an innovative partnership between the New South Wales Ministry of Health and the New South Wales Department of Education. The WIN nurse does not sit alone but operates as part of a wellbeing team in school and works closely with school counsellors, school executive, wellbeing teachers, student support officers and school chaplains. As WIN nurses, we're utilising a universally trusted relationship with children and young people and have an advantage of developing relationships early and being present and available across longer periods. This is especially useful during periods of transition, including at the Kindy Start program, transition from primary to secondary schools, and leaving secondary schools to work and study. Nurses are making referrals and staying with their students to make sure the service met their expectations, if not supporting alternative referrals. Advocacy and connecting our students is the biggest part of our role. Our engagement with community also assists vulnerable groups of students to access culturally safe care, including our First Nations, called LGBTQIA+, and students with disability, often connecting them to lifelong support networks and groups. With a quarter of young Australians now experiencing psychological distress, support for mental as well as physical health in school is paramount. As a WIN, I was initially surprised that mental health issues make up more than 70% of my work. Some of the key ways the WIN nurses in my LHD work to improve student wellbeing are that they serve as a connection point between teachers, students, primary healthcare and allied healthcare services, improving the flow of referrals, appointments and follow-ups. An example of this is the WIN in Eden is working with this week's award-winning new pilot model of care at the Eden High School Wellbeing Hub. The project, known as the Jingi Gudjala Gili Kids Clinic, has been running on the school grounds for the past 18 months. The project is a collective partnership with the school principal, Ms. Viv Chellan, and Dr. Corin Miller, and links students and their families with a GP in school, on school grounds. The WIN, Allied Health Services, school counsellors, NGOs and oral health also operate from this building. The WIN is able to collect all of the students' assessments and refer to this GP in school. In a town where GP appointments are limited, I'm often coordinating referrals to external mental health providers in the primary health setting, including GP referrals to GP mental health care plans, attendance at GP appointments, and supporting GPs with information on who the referral needs to go to, spending time mapping and navigating who is actually available. Our role is much about the relationship and also assist parents when they are managing a child's mental or physical illness. We support the families with children and young people with behaviour problems to access GPs and specialist diagnostic supports, and connecting struggling families with financial brokerage and social support services as needed. The WIN nurses are agents for change for students and their families, promoting care, integration and addressing barriers to this care. We're mobilising more targeted, appropriate and coordinated care, building family engagement with both health and education systems, achieving longer term gains. Our evaluation also identified that school-based nurses have a constant need to be responsive in their local context, and the importance of clarity about the nurse's role to enable smooth collaboration and referrals. The expanded WIN program is funded until June 2024, and the evaluation, which is due for completion in 2024. Thank you.
Thank you very much. I'll now go to questions from committee members. Before I forget about the members who are on WebEx, I wondered if Mrs. Taylor had questions.
Hi, thank you. Thanks so much, Nikki, for coming and doing that. That's terrific. I'm in the park at Nimittabel, so it's great to see you online. I'm really happy for others if they've got things, and I'm happy to follow on because I'm really familiar with the program. But I guess, Nikki, just to start with, congratulations on the recent award that you won at the big evening that was held with the Eden program. I think that's really exciting. And do you think that that's got a potential, that the program that you've run with the GP down there, to roll out across New South Wales, or with the assistance of the WINs?
Thank you for the question. I think the pilot model looks transferable to other communities, and I'll be striving to try and build some relationships with the GP to pilot that in my community as well.
Fantastic. And Nikki, could you tell us as well, seeing you were one of the first WINs to start, and I know that you're here to speak about, your particular community, but could you just give the committee an insight as to how the WINs are going and what's relatively a new program, like across the state? Are they all able to support each other, and is it working, in your opinion, as it had been intended? I mean, you said that you were surprised that over 70% were mental health referrals. I was expecting that, we'd get around that, but that is very high. How are you seeing that being worked out around the state in terms of integration into existing models, say with counsellors and things in schools?
I think that's a great question, and it continues to be a surprise for me. When I first started in this position, I thought that much of my role would be quite broad, and it was a really big surprise that 70% of my work or more is around mental health issues. Across the state, we have some wellbeing meetings. Southerners attached to Murrumbidgee and Rural Far West in our network meeting. And I feel that many of the nurses have similar experiences to me. I can't comment on their work without seeing their statistics.
Okay, thank you. I'm happy to let others ask questions, and then I can come back again.
No worries, Ms. Savelle.
Thanks. Thank you so much, Ms. Rabbit, for appearing today. I wanted to start by asking you and noting your experience as well with this scheme. It's wonderful to hear that you've been in the role for such time. What has your relationship been like with the Department of Education, your local principals, How have things worked at that level between the sort of the two agencies? And is that the case for all WIN nurses, or are there some difficulties there that need to be overcome?
Thank you for the question. I can only comment within my own capacity in my schools. I'm not overseeing the whole project, but certainly it's such an innovative project of health and education working together, and two quite different cultures working together. And that definitely required some initial working out how we each work. I think what was really helpful that this project has a very supportive clinical governance. We have a meeting once a term between the school executive and health, and most of the issues that come up can be ironed out at that point. Building relationships with the school executive in the initial stages was really most important part of the success of this project. And certainly my relationships with the school executive in my schools is fantastic.
And if you could, so just to clarify your role, what is that currently graded as?
So I'm a clinical nurse specialist 2.
Yep.
So I come as a registered nurse, a registered midwife. I have expertise in sexual health, mental health, and drug and alcohol. And I think most of the nurses across the state that are working within the wellbeing nurse role come from quite varied backgrounds, but certainly at a clinical nurse specialist 2 level.
Yeah, that sort of preempted my next question about the sort of the nurses that are working in their roles across the state. Are they people that are working, I suppose, within their scope of practice, or indeed to the scope of their practice, acknowledging you've obviously got some fairly significant skills given what you've just listed?
Thank you for the question. I think we all work within our scope of practice. Our role in schools is quite different to our role in health. We have operational guidelines to support us working within that scope of practice. And certainly it's not a clinical role, it's more a care navigating role. But without my previous skills, it would be quite difficult to triage young people to the correct service.
And given, so you mentioned a care navigator role. Is it the sort of role that could be done by a general mental health trained clinician, a social worker? Just thinking other disciplines that have got similar care navigation skills.
I think it's really interesting that you say that, and it's a great question. I think my schools quite quickly decided that a filter with a nurse perspective was quite important in this role, and that we see some health issues in young people that are quite unexpected. So whilst I speak about mental health generally, there are many young people with mental health issues that also have a parallel physical health issue. And as a nurse, we've been able to look at those young people, correct the physical health issue by a great referral to a GP, and then often improve their mental health.
Thank you. That's really helpful. In terms of the referrals, given you mentioned earlier, I think 70% of people you're dealing with have mental health concerns. How do you go with referral pathways and referring on to services? Are they there, and what are the challenges that are there, if any?
Thank you. There's many challenges in a rural area.
Yes.
And I'll speak to my rural area around finding specialty services to support young people. Taking some time to become aware of what's available in your network and your community is really, really important to the success of this job. And working really closely with primary healthcare, especially GPs, is one of the most important. My relationships with GPs are very important to the success of this role. I think as wellbeing nurses, we've learned how to become very creative. Often when there's not someone available in that role, we are creatively looking for virtual referrals for other services, including NGOs that may be offering quite a similar role, but also advocating for our students to get the very best care. But certainly these days using more virtual referrals to specialists, including psychiatrists and paediatricians online, which is something I had never done before.
Yeah, wonderful. I might hand to one of my colleagues now. I'm just mindful of the time that we have
Any
left.
questions from Mrs. Carr?
I've got a couple, but
Sure.
you
No,
go
go
first.
ahead.
Oh, okay. Thank you very much for being here, Ms. Rabbit. And I just really wanted to follow on from the questions of my colleagues in relation to, I guess, some of the challenges of whether there's adequate support outside of the school, accessing resources in rural communities. And I'm also wondering, and perhaps the program is too new, are there issues for handover? So when a student is leaving school at year 10 or year 12 or at some other point, is there a pathway to make sure that they're sort of handed over to somebody who can help them navigate their way through their particular mental health needs and access appropriate services?
Thank you. That's a great question. I think in New South Wales, working in Cooma, we have great difficulties finding some psychiatrists to refer to, but we are filling that gap with virtual care. Certainly, periods of transition are the most important part of a young person's life, and much of the work of the school wellbeing team, including the school counsellor, is finding young people a service to work with them into the future, especially leaving school.
We've discussed a lot in this inquiry the importance of somebody who has mental health issues, who can help them navigate through the system and help them perhaps understand their own issues and connect them with the right people. I'm just wondering, listening to what you're doing, and I realise that you're much more involved in primary care than simply navigating, but it seems that you also provide a really important role helping students navigate their way through the whole of the mental health and health system. Would you comment on that at all?
Thank you. Yes, I think linking young people with a GP is a GP for life. And if our first appointment with a GP is not great, then I'll keep advocating until we find someone who that young person has a relationship with. But also I'm looking at care navigation services, especially in mental health. It could be an NGO providing a Happy Healthy Minds program. It could be other long-term mental health programs, but certainly helping young people become aware of what's actually in our community and advocating and helping them attend. So it could be Headspace, it could be a stepped up, stepped down arrangement between an acute mental health service such as child adolescent mental health and then step down to Headspace. And much of my work is around just making sure that those relationships work. So a young person may go to see a psychologist at Headspace or a private psychologist and not make a great connection. So my relationship is about checking in, not opening the client and closing the client, but staying with that client for a longer period of time just to make sure that the referral was successful.
Okay, thank you very much. Thank you.
I have to come back to Mrs. Taylor.
Okay, you're right, Amanda, you don't have any?
I did. I came in with loads of questions about referral pathways that have all been answered beautifully in both the opening statement and all the others of questions. Of course, I'm delighted to hear how involved the relationship with the GP is. So I'm happy to pass back to you, Mrs. Taylor.
Oh, no bias. The GPs and the nurses, the Honourable Emily Saval and I have to keep Dr. Con in line. Nikki, don't you worry. I'd just like to ask you two to just, and obviously because I'm familiar with it, but just to explain how important, just going on a bit from what the Honourable Emily Saval's question was, in terms of, you know, the importance of having a nurse in those roles and how you shaped those roles in terms of what you're doing, Nikki. So if you say, you know, like looked at a care navigator when you said you do a lot of navigating when we put care navigators into hospital, how that just wouldn't work in this situation. But can you explain to us why it's so important to have an RN in these positions?
Thank you for the question. I think I have many scenarios of the success of working with young people where having a nurse lens was quite useful. And in our wellbeing team meeting, we discuss students on a weekly basis and work out who's best placed to work with a young person when they're referred to our learning support team. Sometimes the very first point of recall is a school counsellor, but I'll hear some things about the student that makes me think they may have a physical health problem. And so we will work really tightly together. So the school counsellors and I work very well together in all of my schools, secondary and primary schools, to work out what's going on with a young person. And I think my school counsellors will often provide examples of times where they had been seeing a young person for anxiety or some other mental health issue and hadn't really worked out what the core of that issue is. And so sometimes a referral to me brings about a GP appointment, some blood tests, some anemia diagnosis, or some other diagnosis. And it may have been that I looked at that young person and saw some physical health issues. And then together we got some treatment for that issue and improved that young person's mental health.
Okay. Can I thank you? That actually really explains it well. The other thing I just wanted to ask you to reiterate for the committee, because it's something, again, that I hadn't thought about when all the pilots started, because we hadn't envisaged it carrying through primary and secondary. Can you elaborate to the committee the importance of maybe when you see someone, I don't know, at Cooma North Primary, and then you're able to follow them up in that first year in high school, and how important having you working across those different sites has been?
Thank you for the question. I can think of a young person I'm currently working with that fits into that scenario. So I have a young person who I met at primary school in year 5. She had some issues around school refusal. It was quite obvious there were some relationship issues, some bullying issues. The school proactively was working to sort that out. So in year 7, she decided to go to a private school that was also locally accessed by her and her family. And in year 8, she arrived at my public secondary school with her mum for an enrolment interview. I noticed her in the corridor and remembered our relationship and remembered her anxiety. I chatted to mum about anxiety when she was at primary school, and mum felt that she'd probably grow out of anxiety. So after the meeting, the principal realised that I had recognised the student, and we had a little bit of a chat about how we could best support that student at high school. I then called mum and introduced myself. She remembered me from primary school. And we worked on some plans to help the student be successful at high school. And quite soon that student started some school refusal. So I checked in with mum, we sent her to a GP, got a GP mental health care plan, and she started seeing an external psychologist once a week, which was quite useful. We also connected her with a school counsellor, gave her some other check-in adjustments at school, and she's eventually started some medication for her very treatable anxiety. She's now attending, I think her attendance this term is 91%, and previously it had been 13% or not at all. So I've really have enjoyed a relationship over a longer period of time with that family. And recently, as part of our evaluation, I asked that mum to fill out a survey just around her experience of working with a wellbeing nurse. I have no idea whether it was positive or negative, but I presume positive.
And just my final question from me, Nikki, in terms of, say you, how do I say this? So if you see someone in primary school, like you explained with this person, how often does that happen where they'll actually reconnect with you a year later or 2 years later because they feel safe within that space of working with the WINs? Are we seeing that happening across the board?
Thank you for the question. This happens a lot, and I feel like the luckiest person in a school, because I'm the only person in school that goes to a primary school once a week and then is in a high school 3 times a week. So I have this very lucky position of knowing that these children through primary school and into high school. And I definitely managed to leverage that relationship to then handhold some referrals to other services, including the school counsellor, the student support officer, and we all work together around that relationship.
Ms. Suvell?
Thanks,
Great.
Chair. Thanks so much. Look, just a final question or two from me. There's obviously the program's got quite a broad focus, the WIN, but it is evident there's quite a heavy focus on mental health throughout the program, as is sort of evidenced by what we're discussing. CNS2s, it's fair to say, are very experienced senior nurses. Are there enough appropriately mental health credentialed nurses across the state?
Thank you for the question. That's a hard question. I think that there's definitely not enough credentialed mental health nurses across the state, as in that seems to be the reality of health. I think that we're fitting some gaps in the health service at an earlier intervention point, and certainly having a broad experience. Not everyone in our WIN team has experience in mental health, but also building a relationship seems to be the most important part of our work.
Thank you. You mentioned not everyone in the WIN team has experience with mental health. Are all the WIN positions filled? Do you know?
Thank you. I spoke to the ministry yesterday, and I think we've had this, we have 96 out of the 100 WINs filled at this time. There's some WINs on maternity leave. Not everybody is mental health trained or with a mental health background. We have quite broad backgrounds across the state. Because we're not providing, all nurses are trained to provide some kind of triage when it comes to mental health symptoms, and we're providing a service that refers young people, or children and young people, to a mental health service. We're not holding that young person providing those therapies. So we're referring to the school counsellor, we're referring to private psychologists, we're referring to GPs, a lot of referrals to GPs.
And do you
and
feel
luckily
like that,
I have some
Yep.
GPs that have great skills in mental health.
Yeah, that would be of benefit, which preempts my next question about the referrals and how effective you're finding that. Is it the case that you can refer someone locally and then that they have a relatively good result, or are you seeing these people multiple times because the services aren't sufficient or aren't appropriate?
Certainly there's a mix of both. I think I often see young people more times than what I think I'm going to see them, and certainly I'm not going to start seeing a young person and then stop seeing them once I've made a referral, because I don't know that referral is going to be successful. And there's many young people that the first person I've referred them to, it's not that successful. And luckily, I'm able to check back in with that young person and work that out and then make another referral. But certainly there are wait lists, but holding that young person within my WIN program is really, really important to that young person's success of feeling like someone's working with them.
Absolutely. Is there any data, do you know, about how long people are being held in those WIN programs? Around, you know, I'm just thinking of the access issues, if there are any.
I can take that question on notice, but we have the Wellbeing Health in Reach Nurse program pilot evaluation with the next evaluation coming due next year.
Thank you. Thanks, Chair.
Thank you very much. Thanks so much for making the time to provide evidence today, and if there are questions on notice, the Secretariat will be in touch with you.
Thank you.
Thank you.
Thanks, Nikki.
I'm now hot. Is anyone else?
Welcome. Thank you so much for making the time to give evidence today.
Very pleased to be here. Thank you for the invitation.
Could you please state your name and position title and swear either the oath or the affirmation?
My name is Catherine Mary Lowry and I'm the Mental Health Commissioner of New South Wales. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Would you like to start by making an opening statement?
Yes, thank you. So as I said earlier, thank you so very much for inviting me to be here today. The topic of your inquiry into equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales is so very important, especially when we are looking at how our communities are experiencing the impacts from COVID, bushfires, floods, and the many things that have really impacted upon psychological well-being and mental health over this last period. So I also would like to pay respects to the Gadigal people of the Eora Nation upon whose land we are all meeting and discussing today, and I especially want to acknowledge people with lived experience of mental health issues, caring, and especially of those who have lived experience of trauma and suicidality. And of course, I think that is so key to the discussions that the committee has been holding about how to understand ways that we can better improve service delivery to improve the outcomes and, of course, the lives of people who live with mental health issues. So the Mental Health Commission's role is to monitor and review and advocate for mental health reform. And in New South Wales, we're coming to the end of the 10-year Living Well strategy. And as we reflect upon that, we really have seen that whilst there have been great efforts in improving mental health services in the community, what we are seeing is that there are still gaps that exist, that there are inequities across regions and across vulnerable communities and communities of special need. And so for us, this means that there are always ongoing efforts to be made. And as we move forward, we really will need to consider how we can really embed a whole of government response that strengthens community recovery, embeds lived experience and invests in evidence-based community supports. And so whilst we look backwards for a moment, I think one of the key issues for mental health and community mental health is around our comparative levels of funding. So whilst we have had continuous investment in community-based supports, that has not been as invested to the level of inpatient and clinical hospital-based services. In New South Wales, according to the Australian Institute of Health and Welfare, in 2021, New South Wales had the lowest per capita expenditure on community, had the second lowest per capita expenditure on community mental health in Australia. So community mental health spend per capita in New South Wales increased by only $2.23 in the past decade to $88.83. So this is below the per capita increases for Northern Territory, which was just over $28, in Victoria almost $17, and in Queensland that was $5. So New South Wales per capita funding on community mental health for 2021 overall was the second lowest nationally at $89, which was just ahead of Tasmania at $79 and well below the Northern Territory at $156. Meanwhile, the national average was $113. So New South Wales per capita spend has been consistently below the national average for the last decade. The Commission would like to see an increase in the proportion of expenditure at a minimum in line with the national average. And this has also been advocated for in our recent submission to the Special Commission of Inquiry into Healthcare Funding. In terms of equity and accessibility, this inequitable distribution of resources, whether that be staffing, services or funding, perpetuates a model that leads to inequitable outcomes and, moreover, the inequitable opportunity to live well with a mental health condition. I understand the committee has already heard on a number of important topics in preceding hearings, and so I really would like to contribute and further any questions that may have also arisen from those for you. But of course, one of the issues that has arisen has been the intersectionality that exists in mental health across all areas of life and for many diverse population groups. This has also been increasing attention to emergency services responses, and the Commission has been appalled by the recent tragedies in New South Wales and acknowledges the efforts to provide more compassionate and humane care to prevent these occurrences. Collaborative efforts to develop a person-centred, safe and trauma-informed response are needed. Discussions that focus on supporting people at their most vulnerable, while acknowledging those who may be vulnerable to risk around them, is essential. But of course, we want a system that has early response and support capacity for our community mental health teams to have assertive outreach teams, to be resourced together with services that can wrap around the person, whether that be psychological support, housing support or crisis care. We have also continuously heard people calling for a system that lifts the burden of obstacles in reaching the right care at the right time. It's not only a matter of having the level of services improved, but accessibility to those. Obstacles of wayfinding or navigation are continually raised by the community in consultations with the Commission. Equally, those consultations emphasise the importance of expanding the lived experience workforce across all levels of leadership, service design and delivery because of the known benefits that this has to offer. Peer workers connect and support with people, and they can also help people navigate through the complex mental health system when they are most unwell or in need of support. The Commission has looked at this ourselves, and we have piloted a navigation peer model that has had a resounding impacts across those particular communities where we've trialled them, and we hope that there will be good evidence for others to take up this approach. The Commission recommends better integration of care, and that this not only occur between publicly funded mental and physical health services, but also in partnership with the non-government, private and community managed sector, and importantly with local communities. To address these issues, we suggest a rigorous focus on collaborative commissioning, regional commissioning and establishing place-based partnerships as part of a cross-agency response and in a less stigmatising community settings.
this is necessary to bridge the gap of the missing middle, where people are told they're not unwell enough for the support offered by primary care services and yet do not meet the arbitrary threshold to be able to access tertiary mental health services. So, because this approach still focuses on what is provided, not what is needed by the person. Across these and other areas, the Commission is committed to working to elevate the voices of people with lived experience of mental health issues, their families and their carers and kin, to improve equitable outcomes across our many different communities, across towns and cities and age groups, while acknowledging cultural diversity and the range of experiences of mental ill health and suicidality can severely impact the lives of so many. So I look forward to our discussion this afternoon. Thank you.
Thank you very much, and thank you also for your very detailed written submission on behalf of the Commission. I've got a few of my own questions, starting with community treatment orders.
Yep.
I understand from your submission that the Commission has recently undertaken a project to understand the experiences of people affected by CTOs, and that's been substantially negative for a large number of people, and you've made reference to the work being done in other jurisdictions to review the way that CTOs are used, and I was hoping that you could expand on that, on what's some of the work that we should be considering that's happened elsewhere.
I think that the way that community treatment orders are set up, and this may have been said by other people before me, which is that it's very hard to establish a therapeutic relationship when it is compulsory care, where it is coercive care. And so because mental health does have a recovery focus in the way that it works, CTOs do bump up against that very much. And so whilst we can have people who are said to be non-compliant, it actually can also be seen as expressing a choice about how they are treated, about how valuable that treatment is, and also about understanding how people may feel about their human rights, because coercive care, whether it be seclusion in an inpatient unit or a compulsory treatment order, is also about an individual's human rights. And in other jurisdictions, and I can provide more information to the committee outside of this if you wish, but other jurisdictions, that is what they are looking to. How can we support an individual on their recovery journey? And by looking at what is most effective in that, and utilising coercive practice less and engagement more. And I think that in other jurisdictions, and we have looked at international literature, where it also states that the difficulties around community treatment orders are about that, not only that coercive aspect, but also an assumption that that is going to be the most effective intervention. When we know that if people are on community treatment orders, that they would have a range of issues that would impact not only their engagement with mental health services, but also even attending and engaging with mental health services. So there we're talking about housing or employment or psychosocial services, their natural support networks that they may have in their community. So when we start to look at the whole person, it's not just not engaging with the service and therefore they need compulsory treatment. It's about understanding how can we support the whole person before we get to that point.
Thank you. And we've already received a large volume of evidence about the need to increase resourcing to community mental health services to provide additional support to people, whether they're on a CTO or not. But I'm interested in your view, whether you think we need to review the Mental Health Act.
So I didn't hear the last part.
Do you think we need to review the Mental Health Act?
Oh, do we need to move? That's a great question. And my answer off the cuff, so to speak, would be yes. And I think the yes is because we need to consider CTOs in the broader aspect of a person. So if we were to do any review of the legislation, you would have to have the voice of lived experience in there. And that's one of the projects that the Commission is currently doing on CTOs. A lot of the research is very much about compliance, medication, and risk and safety. But what we want to investigate more and to engage with people who've been on community treatment orders about to understand the broader impacts it has upon them. Because if we are about having trauma-informed services and trauma-informed approaches, then being on a compulsory order isn't necessarily very trauma-informed. So in our piece of work that we are going to be finalising next year, they are the perspectives that we want to bring. So in looking at any review of the legislation, I think it is imperative that the voices of people who are subject to that legislation, who are impacted by that legislation, and that includes families and carers, do need to be part of that, because I think contemporary legislation needs to understand how we evolve with models of care. And we've seen so much innovation in many other areas in supporting people with mental health issues, whether it be having alternatives to emergency departments that really go to where do we provide mental health care. It's not always in hospitals. It's not always through our legislation. And so what we want to understand better is how can we have a service framework that isn't reliant upon involuntary admissions or other coercive practices.
Thank you. Elsewhere in the submission, you've mentioned the mental health investment decision tool.
Yes.
Could you explain to us how that works?
Yes. Thank you. Absolutely. So in the Living Well in Focus mental health strategy that we released 4 years ago, this was one of the recommendations. And so I'll go back in a little bit of history to give you a bit of context. So in mental health, we can be very good at planning hospitals and planning community mental health services. And we have a model called the National Mental Health Service Planning Framework that does that. It sets, these are the standards that you would need for a hospital. These are the standards you would need for how many beds for young people, older people, and supported accommodation. And of course, we know people don't live in a hospital. They live in the community. And so we were really after how can we plan and allocate our resources most effective, that is about early intervention and prevention, and about supporting people whenever they become unwell, to get the supports they need to keep them well, or to have early enough intervention so that their illness doesn't progress to the point where they need inpatient care. Of course, for some, that's the most appropriate type of service and specialist care that they need. So our model is a modelling tool, which means that you can put in the variables and have those calculated. So it's all about community-based care, which is different from community mental health. So it's not a clinical model. It looks at what are we doing in education, what are we doing in housing, online services, peer-led services, because we don't plan those. We know that there might be evidence and emerging evidence, but we don't look at them as a suite of services that support people to be well. And of course, if we can plan and coordinate our resources and investment in those areas, what we will do, and this is what our model has shown us, that you have less presentations to emergency departments, less need therefore for inpatient beds, but it also means that that frees up beds for the people who are most in need of specialist inpatient care. You also find that people's psychological health improves, so that whilst they may be in the severe category of mental health issues, mental health illness, that will go down to medium and medium to low. So it really is about supporting people early and giving them those supports in the community. It's also about helping our young people, and we have, as I said, the interventions in schools and education, because what we want to do is, as you probably know, that the majority of mental health issues arise before someone's 16, and then the remainder of the impact is normally then up to around age 24, 25. So it is really important to understand how do we set up our young people to lead mentally healthy lives, but when they do become unwell, that we are be able to get in early and to support them in their environment and support their families. So that tool has been shared with New South Wales Treasury, it's been shared with Health, Education, other departments, we've shown it to the Commonwealth the government as well, because we have to be smarter with our money, but we have to get the better outcomes, not only for the bottom line budget for New South Wales, but for people. And it's always about people for the Commission. And we always know that the results that we are after are the results that people are after, which is when I become well, that I get a service that I can access. That when my son is in high school and he has his first episode of psychosis, that I know where to go. My school understands him. These are the things that are important. So in our model, we are really looking at how can we have a cohesive strategy about community-based care that can sit alongside our clinical services so that we have a person-centred approach, because people don't live in hospitals, they live in communities, and it's their communities of support around them that will sustain their mental health recovery journey.
Thank you. Ms. Sibyl.
Thanks, Chair. Thanks so much for appearing today. It's wonderful to have you here. In terms of the role of the Commission, I just wondered if you could talk through your view around the function of the Commission and what this also has tangibly led to in terms of improvements in the sector.
So what was the last point?
What has it tangibly led to in terms of sector improvements, the role of Commissioner?
Thank you. So the role of the Commission is to improve the mental health and wellbeing of the community of New South Wales. And we do that through three things: advocacy, undertaking reviews, and monitoring and reporting. So the Commission holds no budget. We don't fund services. We don't mandate policy. That is up to each individual agency. So in our role, what we do is provide frameworks, as we did with the suicide prevention framework, Shifting the Landscape, which is there for not only to provide a statewide strategic approach, but also to guide how each agency can then interpret and develop their own suicide prevention strategy. So, for example, when the first framework was released 6 years ago, it was accompanied by about $80 million worth of investment that led towards zero suicides. So just using that as an example, through that work of the Commission, we have now got a regular suicide monitoring system, which New South Wales did not have before. We had a coordinated program which was called Towards Zero Suicides that did focus on education, training, standing up new services such as safe places, alternatives to EDs, and supporting peer-led initiatives, as well as establishing community collaboratives. So the work, say, just using it as the example, that would be one of the tangible kind of results.
Yeah, I suppose given it's a framework and there's no requirement to implement it, I suppose that's one potential obstacle. But then I suppose the other things that we've heard in other submissions and in hearings that we've held is about the level of distress that exists and is increasing within the community. So if in fact it is the role of the Commission to ensure that mental health advocacy and as you say, what is it that's, I suppose, not working as well as it could be in ensuring that those levels of distress are lower?
So I'll just go back to the suicide prevention example. Is that our reports also go through Cabinet, and so I think that does give a level of endorsement to implementation of the frameworks. And there also is a mental health task force which is chaired by the Health Secretary that has all of the agencies, Human Service and other associated agencies that sit on that. So, for example, the suicide prevention framework goes through that. Our reports on progress with implementing Living Well in Focus go through that committee. So we do engage very much at that whole of government, cross-government level to not only discuss how engaged and other agencies are, but also what they are undertaking. So, for example, we have just completed the mid-year progress report on implementation of Living Well in Focus, which will be published shortly. And there we really identify not only what each of the agencies are doing, but our role is also to hold up a mirror to them to where they need to do further effort, so that it is very clear about where, in regards, say, to Living Well in Focus, about where work needs to be done, but also to be very clear about the expectation that, for example, there's only 2 years left in that strategy, so this is the time that we need to focus. We're doing the same with our suicide prevention framework, Shifting the Landscape, where we are having a reports in years 1, 3 and 5 that do the same, that we ask agencies where they are going. Because
I suppose I'm just trying to understand whether holding a mirror up to an agency is sufficient to ensure that those goals are met.
Yes.
The plans that we've heard, again, other evidence about that, the Living Well strategy and framework, and indeed this is now, is it the second iteration of the plan?
Yeah,
But that there are still things in that initial strategy which would work well in merit, but that have not been implemented.
I guess there are two things there. One is I could think of, let me think. Okay, so one of the recommendations out of Living Well in 2014 was that both Morisset and Macquarie, those hospitals, the freestanding hospitals, were to have their services transferred to the community, because it was really focused on standalone psychiatric hospitals. One of those hospitals is progressing towards that, and that's Morisset. But the other standalone hospitals, and I think mostly now Macquarie Hospital, has not been progressed in that way. So that, I agree, that's one where we haven't. But that is also one where we continue to prosecute that case with the ministry, and the ministry very much understand that it's about having contemporary models of care where people can have the best type of care. So, for example, if I use Macquarie Hospital, where there is an acute inpatient unit, that is a freestanding acute inpatient unit. So we know the high levels of comorbidity between physical health and mental health, and you're on a site where there's no physical health services and supports for people. There's no imaging, there's no pathology. So a lot of it is about quality of care and contemporary practices. But yes, not every point and Living Well had 141 recommendations. Living Well in Focus had 24. So our current monitoring and reporting is on those 24. Some of those other issues also have been overtaken. They were written 10 years ago, so they have been overtaken by other events. But we have had a lot of success. Under Living Well, for example, we've now got the Pathways to Community Living initiative. So, and that is for people who were in those large institutions, sometimes for decades. So those things have really made a tangible difference to those families and those people.
Yeah, absolutely. And we have heard evidence about the merits, certainly, of HASI and PCLI. My next question is around the community treatment orders that my colleague touched on earlier. And we know that the instances of those have been increasing. We had earlier evidence from the Mental Health Review Tribunal around the record keeping and the fact that this wasn't digitised. What has the work done? What has the Commission done to work with the Tribunal in this space, if anything?
So when the Commission was first established, we entered into an agreement with the Tribunal to undertake some research to then discover that they did have paper records. So we actually, as part of that project, we did fund them to digitise some of their records. That is an ongoing issue, though, and I think one that needs to be done at that broader systems level of funding and resourcing for a whole range of reasons, not only for research to understand what's happening, but also it's about an accountability mechanism and transparency. And I think in mental health, transparency and accountability are key. That's why the Commission publishes our reports, previously, some of the reports that we wrote, because they would go to Cabinet, they would be Cabinet in confidence. But now we have arrangements where we can table those. And I think this is the other thing about having that accountability back to the community, and especially in an area like the Mental Health Tribunal that deals with so many different cases of complexity, but also to understand that whether they be civilian cases or forensic cases, if our goal for the Commission, but I think it's the goal for our mental health system, is to support people to live well in the community on their own terms and to have the services and supports that they need when they become unwell, the Tribunal is a key player in that. And more broadly, I think the way that the Tribunal's information and data can be shared so that we can have those upstream interventions in place so that people do get the care before they come, into contact with the criminal justice system, that they do get diverted away from the court system. It's a large area, but I would say it's important because their clients are the most vulnerable in our community.
And so just to sort of draw a line under it, when was the Commission established? It's probably in your submission.
2012.
2012. So you've started working with the Review Tribunal in 2012 to digitise
2012, 13, something like that. I wasn't
so
there
10
at the
years down
time.
the track, it still
yeah.
hasn't been done. Yep, okay. Thank you. Thanks, Chair.
Mrs. Carter?
Thank you. Thank you for being here today. Actually, my question follows directly on. Thank you for that date, because I wondered if you could, discuss what's changed over the last, 13 years of your operation. What
in the sector?
Well, in the needs that
in
are
the
being
need.
addressed,
all right,
and in the ways in which they have been addressed.
So over the last 10 years, what we've seen is increasing rates in psychological distress, but most of what we've seen, I would say, is not only the increased rates of psychological distress, we have seen increasing presentations to emergency departments, demand for inpatient care. We've also seen that, though, across our GP practices, where mental health is now the leading reason why people attend a GP. What we're seeing is also that more latterly is the compounding impact of experiencing numerous adverse events. And I think that in one sense, COVID did bring together a whole of government approach in understanding that. But I think the big challenge that has really emerged is how do we understand distress, which is different from...
Can I just stop you? Because I
Yeah,
suppose something I'd like to explore is, if we've been working at this in one way for 10, 12, 11 years and things are getting worse, is that an indicator that we should be thinking about doing things very differently?
What we need, yes, is a short answer. And the ways of different working are about bringing people with lived experience into those services to have their voice as part of the shape. And we have seen the increase in the number of peer workers, for example, across the system. But of course, in mental health, early intervention prevention also sits with our primary health networks, and it does sit with our GPs. So it is very much about how we also need to explore how to work differently with those. We have great examples of integrated care models where you'll have a GP, a practice mental health nurse, a psychiatrist, and a peer worker. And we know that those models work really well, because not only is the GP then supported by...
So could you tell me some examples of geographically where those models exist?
Those models, I can provide that after
that would be wonderful.
the
Thank
meeting,
you.
yeah.
Yes.
But I've visited a couple of them, and what you find is that the GP feels supported in managing mental health clients, because it isn't always their area of expertise. So they do know that they've got a mental health nurse, a peer worker, and a psychiatrist there. But it also means that the client can also, in between visits to the GP, have that specialist support. And as I was saying earlier, it's about holistic care. So in one of the integrated care centres that I visited, you've got the peer worker taking the person to the dentist. You've got them they're going to other health supports, which is really important.
So I think that ties into your recommendation in relation to employing peer navigators as wayfinders.
Yes.
What would this look like? This looks like somebody who accompanies a mentally ill person through all of their health journeys, or what does that look like?
So you're just about spot on, but it's not only about their mental health journey, it's about what they need in their life. So it could be about housing. It might be going to put your name down on a public housing waiting list. So it really is about what supports does that person need to get to where they want to go to. So it can be absolutely through their mental health journey and those services, but it can also be to those other parts of their life that they need. And stable housing is fundamental to good mental health, for example.
Does the fact that we need to employ navigators to help people work their way through health and government systems, does that indicate system deficiencies, or does that indicate that people with mental health challenges have particular needs?
I think it's a mix. I think the mental health system as it is a very complex system. You've got private, you've got public.
What would be your recommendations, given your 10 plus years of experience with the Commission, of how it can be made more person-centred and accessible to those who are ill?
The way to make it more person-centred is to have collaborative planning and collaborative funding. So when the earlier question about the planning tool that I was talking about, it's no use having an intervention for someone's mental health if they're being discharged to homelessness, or if they're going home and they have no natural support network. So it's about integrated care planning. It's about having assertive outreach team and follow-up. It's about having the person having their own natural supports. And it's about having compassionate, trauma-informed care, because what we also find is that people will not reach out if they feel they're going to be treated with stigma or discrimination, or if they were traumatised the last time that they were, say, in an inpatient unit. So it's about culture, it's about integration, and it's about finding a way where we can stop thinking about silos and what we're providing, and about understanding how we can have that ease of access points.
And that's the work that you've been engaged in, breaking
That's the
down
work
those
that we do.
silos?
So we, because we don't fund services, but like I was talking earlier about a pilot that we did on peer navigation, so we will invest in areas that we think need to be highlighted, and then that provides evidence and a showcase to other agencies. And in fact, we funded 2 peer pilots in Western New South Wales Local Health District with 2 Aboriginal peer workers, and they were so successful the LHD now wants to roll that out further. So I think it's also about understanding that you can have a top-down approach and a bottom-up approach as well. And I think because the other complexity in all of this is that every community is different and every community has their own different needs. So that's why when I talk about regional planning, it really is about what works for that region, because what will work in Penrith won't work, in Orange, for example.
And in terms of the assertive care that you discussed, is there a tension between assertive care and patient autonomy? And if there is, how do we resolve that?
So assertive care is really about reaching out to people and checking in with them. It's not about
but if
surveillance.
That patient doesn't want to be checked in with,
yes,
where is the tension between assertive care and autonomy?
I totally understand your point. Yeah. So it's not about surveillance per se, and it's not about surveillance, I shouldn't even say per se. It's not about surveillance and checking in on people. It is really checking to see that...
But if the person with mental illness doesn't understand that nuance, how do we deliver assertive care, which I think is a very good model, but in a way which the ill person feels supported rather than checked in on?
So that all comes down to how we do our discharge planning. So if we are talking to people around what they like, how they want to have their services planned, and it also works the other way around, that you can have like an advance notice about, if my mental health does deteriorate, this is how I would like you to engage with me. So it is very much about how we have those conversations, because you are absolutely right. It goes back to the point with the CTOs. If people feel that they are being coerced into treatment or coerced to do things, then that is just not good for their mental health at all. And it is about having their participation, engagement, and listening to their needs. So with assertive outreach, it really is about how to support that person in the best way that they need. It's not about saying, here's the 5 steps that we're going to do and you're going to, go through all of them.
And you think peer workers should be trained in assertive care?
The Commission very much supports multidisciplinary teams, because we do understand that you need, psychologists, social workers, peer workers, you do need allied health workers, and you do need clinicians. But peer workers can relate and support to people in such a different way. And of course, because their journey can be very similar, and I think it also models hope, because hope is a very important thing in mental health. When you're having your worst day, to know that there is hope, that there will be a better day, but also that there is someone who is looking out for you. And that's why we found that, over the last, few decades, when we have had peer support or other services like there used to be, FAMs and, partners in recovery, all of those services were supported because they were one-on-one, and that the individual person could elect how they engaged with those services and supports.
Ask a practical question in relation to one of your recommendations.
Yes.
And you indicate that we should scale up the peer and carer workforce to meet the demands of the population. We've heard a lot of evidence about the real crunch on the workforce. How are we going to scale up the peer and the carer workforce?
So the way that we do that is by, first of all, training, and there's the certificate 4 in peer work.
But how are we attracting people? Who will we get to train?
Okay, so the way that that is being undertaken at the moment and has been effective is by offering scholarships, free. So basically, it is scholarships for people who can who wish to undertake that training. So, for example, the Commission has funded 100 scholarships with the Mental Health Coordinating Council, called the Mental Health Coordinating Council is also an RTO. So.
Sorry, over what time period have those scholarships been funded?
They're over a 2-year period. So
and they're going to continue?
At the moment, they were one-off, but at the moment we've also got Commonwealth funding for scholarships in New South Wales as well. But it does come to my next point.
And all those places were filled?
Yes.
Great.
So, but there are rate limiters, and these are the things that that the Ministry of Health very much also need to engage with. So when we have a peer worker or an Aboriginal health worker, they have a placement or they have a trainee position, and they really are part of the issues that we need to address, because there aren't enough of those. So whilst we could give more scholarships to people...
How can we create more placements? How can we create more placements?
Exactly.
That's my question to you. How can we do that?
Well, this is the question that I've put to the Ministry, because these are services that...
so it's not an answer that you have.
It's not an answer that I have.
But you can't provide the answer to that.
Well, because essentially I would say it's that those positions need to be funded. They need to be funded by the Ministry, and also whether we broaden out from public health to our community managed sector as well. Because
sorry, I don't really understand what you just said.
The community managed sector are...
No, but when you say broaden out, what do you mean?
So at the moment, the community managed sector isn't funded for trainee positions or for placements. So you would need to provide that, because you can't have people training and going to work without getting,
Great.
an income, right? So so that would be part of our solution, that we look beyond the public sector to understand where would we want to see this workforce to be working. And it is across that spectrum. We want them in the community, we want them in the community mental health services, we want them in inpatient services, we want them in the forensic hospital, we want them in prisons. This is where we want peer workers. So it's not just about what's in this hospital in the local health district. It is wherever people who have a mental health issue can get value out of having a peer worker on their team, then that's where we want peer workers to be.
Okay, thank you very much. Thank you.
Thank you.
Thanks.
There's 1 minute left. If you'd like it.
I'm all right, yeah.
That's all right. Thank you so much again for the time you've taken to give evidence today and also to prepare the written submission. The Secretariat will be in touch with you with any questions on notice.
Thank you very much. I really appreciate the time.
Thank you.
Thank you.
And good luck with your deliberations.
Thank you. We have a lot of work to do. For the interest of those in the gallery or streaming online, we're going to be taking a break for 15 minutes and we'll be back at 3:30. We'll get started, and just wanted to acknowledge the room seems very empty, but some of our committee members are on WebEx today and they're watching the live stream of the proceedings.
Okay, thanks.
Welcome, and thank you for making the time to give evidence today. Could you start by each stating your name and position title and then swear either the oath or the affirmation?
Yep, all right, I'll start. So my name's Liz Ray. I am the CEO of Nepean Blue Mountains Primary Health Network, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
I'm Craig Parsons. I'm General Manager for Partnerships and Innovation at Northern Sydney Primary Health Network, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making an opening statement?
Yeah, thank you. So good afternoon. Craig Parsons and myself today appear on behalf of 10 New South Wales primary health networks, commonly known as PHNs, which is what I'll refer to them as. Primary health networks have three main roles. Firstly, to support general practice and other primary care providers to deliver high quality care. Secondly, we commission services that meet the needs of the community. And thirdly, we work with others to integrate care so people don't fall through the cracks when they move from one part of the health system to the other. So about 50% of the funding, the Commonwealth funding that we receive as primary health networks is focused on mental health and suicide prevention. So quite a significant part of our work as PHNs. And last financial year, primary health networks in New South Wales and ACT commissioned approximately $200 million of mental health and psychosocial programs, providing just under a million service contacts for more than 135,000 people. Each primary health network and local health district, or LHD, have developed joint mental health and suicide prevention regional plans, and these are currently being updated now to reflect the activities of the new mental health and suicide prevention bilateral agreement. However, the capacity for local health districts to participate in joint planning and also to advance or implement those plans is quite limited, despite a lot of goodwill. And there is limited accountability mechanisms in New South Wales. Our submission outlines the current challenges and major gaps of concern, including lack of investment in mental health services, poor navigation, duplication of assessments, barriers to accessing services by community, and workforce issues. The submission includes 15 recommendations to improve equity, accessibility and appropriate delivery of outpatient and community mental health care in New South Wales. And all these recommendations and the points in our submission are underpinned by a really common theme, and that is the need for stronger commitment, adequate resourcing and better accountability for local health districts and primary health networks to work together for a more integrated mental health system. And this is essential if we're looking to maximise the health dollar, reduce duplication and provide better access for people in our community to mental health and suicide prevention care. Thanks.
Thank you very much. We'll go to questions from the committee. Perhaps Mrs. Carter first this time.
Thank you. Thank you, and thank you both for being here and speaking on behalf of your organisations. I wonder if I could just take you straight to recommendation 4, which is in relation to disordered eating and eating disorders. So as I understand your submission that essentially LHDs outside the cities have no resources for disordered eating and eating disorders?
I think the provision of eating disorder services, particularly those in the community, are quite minimal. Over the past few years, local health districts have increased their capacity, but there is still that gap in particularly outpatient treatment services for people experiencing eating disorders. And then we further see that in the community when people are either before they require hospitalisation and inpatient treatment or following inpatient treatment. Those services in the community are difficult to access and often quite expensive as well.
Do you think that GPs are well enough educated and well enough resourced to be able to identify, diagnose and support people presenting with some sort of disordered eating?
I think there's still a way to go in terms of educating and supporting GPs to be able to identify eating disorders and then appropriately link people to the most appropriate form of care. I think as well in the community there's a lack of practitioners, and specifically practitioners who will bulk bill or can provide affordable treatment for people experiencing eating disorders.
In terms of lack of practitioners and lack of affordability, would that be, in your observation, the same metropolitan and regional, or more exacerbated in regional areas?
I think definitely exacerbated in regional areas. In Northern Sydney, we have one of the highest proportions of mental health clinicians and psychologists, and even there, people will struggle to find a clinician who is experienced and confident to address eating disorders, and a clinician who will charge an affordable fee.
And as we move west into my area, Penrith and the Blue Mountains, Lithgow, Hawkesbury, it's certainly a challenge. And that's one of the things that GPs tell us, is it's not only about their own education, it's about having the appropriate support services, because we know in this treatment it's not just one clinician, it really is a team to make this work, and that's where there's challenges.
And what would it take to fix it?
Well, like everything, more investment. But I think, it sort of comes back a little bit to a lot of the things that we've actually got in our recommendations about, again, trying to reduce the siloing of our thinking and our funding within every sector. And you've probably seen today and in past days so many different organisations coming, probably with quite similar themes. And it's about how do we try and facilitate that linking up, because we know that we can't, there's a finite amount of dollars. But I think we can be a lot smarter if there's some capacity building for us to work together better. So that's definitely part of the solution, as well as investing further services.
We've had a lot of evidence of the value of peer workers, especially peer workers who might help navigate through. I suppose I have a specific question in relation to peer workers and eating disorders, and I understand if you want to take this on notice. I'm aware of some literature in relation to the fact that peer experiences for people with eating disorders aren't always helpful, and I just wondered if you had any comments about whether peer workers were as appropriate in the eating disorder space as they may be in other areas.
That's not my area of expertise, but have you got any comments there, Craig?
I think they can play a role, but I think like with any peer roles, really the framework in which the peers operate is really important to define, and that model of care in terms of the type of support that peer workers are responsible for, and how that links to the broader care team as well.
Yeah. Workforce is an issue that you flagged. Workforce is an issue we've heard a lot about. How do we improve workforce? Any sort of practical suggestions?
Because I think one of the challenges we're all finding, as there has been more investment in mental health, is that the rate limiting factor is often workforce. So what we do find sometimes is that a new service might start and it's just moving one lot of workforce into that new program or new area. So it certainly is a challenge. I think with one of the key things that, we are now, one of the only good things that came out of the pandemic was that I suppose that use of telehealth, people being more comfortable with that. Certainly in some areas across primary health networks, including my own, telehealth psychiatry, for example, has been, a game changer for our region. We know that it's, a real challenge in that regard. But also the investment now in training. We've seen, and no doubt you've heard about the state of general practice, and we're really pleased now to be seeing an investment in, reform in primary care. We need to do that earlier in every sector to be advancing and really forward planning, so we don't get to the crisis point where there's no solution for such a long time. So I think keeping it on the radar, knowing what we do have, a bit of a census, again, not just across New South Wales Health Services, but across New South Wales, across all sectors, primary care, where can we better integrate and link up? we know that some services struggle, say, to have a GP on site at a mental health service, but can we work wiser and smarter by actually not having to directly employ, but actually look at, again, that better relationships and integration and some models that support that? Because it doesn't just happen. It takes time, relationships, and we do need to invest in capacity to do that. And that might be a way we can better utilise the current workforce. But Craig, you might have other comments as well.
I think in addition to those points, looking at opportunities to really increase the skill set and scope of practice of the clinicians and practitioners that we do have. So we've seen great success in Northern Sydney, specific to drug and alcohol, around clinical attachments between general practice and the LHD drug and alcohol services. I think that's a model that could be scaled up and spread across the state for different specialities and different practitioner groups.
I suppose a workforce concern I have is that we keep hearing about the role of the GP, and GPs perform a really valuable role, but it sometimes sounds as if, and this will be added to the GP, and that will be added to the GP, and we've heard evidence that the time that GPs need to spend with a mental health patient is longer than somebody with a spider bite to the finger, and that perhaps that isn't reflected in the charging schedules as well. So I guess I have concerns as to whether loading everything on GPs as things are currently structured is really a workforce answer.
Yeah, and the reality is that GPs see a lot. I think it really goes under the radar. GPs do a lot of mental health care. You know, when you look at, I think recently I was looking at some statistics around the reporting of general practice, who I think it's gone up from 60-odd% to 75% of their perception of patients that come in to see them that report a mental health concern. So, you know, they are already doing a lot, and it's the support that they ask for. Again, I've had GPs say, if we could have, you know, a social worker to help, because we know it's broader than the medical, it's looking at that psychosocial support as well, and looking at those sorts of roles in general practice might make such a difference. You know, that's one role in a general practice that could have quite a significant impact if we just get creative, rather than, you know, building a nice new building and, you know, putting services there. So again, it's about how do we work with our existing to provide that support to GPs so they don't get burnout.
Can I just ask a follow-up on exactly this topic? You know, I share concerns as a former GP of GPs being given responsibility to do things without being given resourcing to do things. And I was interested in your submission on page 14. There's a really interesting example of the Central and Eastern Sydney PHN project, which was GP shared care.
Yep.
So I was wondering if you could explain in a bit more detail how that works, if you know. I apologise if you need to take it on notice, and I'm also wondering if that program's been evaluated.
My understanding is it has been, but I will take that on notice and request that additional information.
Thank you. Really appreciate that.
And GPs love the shared care. I mean, our experience is it's been really positive, because it still gives the GP who's dealing with, you know, or as you know, looking after the patient holistically, and giving that extra support. We have found with chronic disease programs, you know, and mental health programs, that it's been something that's a real support for general practice around those shared care approaches.
Thanks. Ms. Bell?
Thanks, Chair. Thanks to you both for appearing today. I wanted to ask you some further questions in the submission around data sharing. And I note that was part of your recommendations in the submission, particularly recommendation 3 I'm interested in. So in terms of, I found it very interesting that the decision had been made to share the data but not included PHNs when you're commissioning the local services on the ground. Could you explain to the committee what impact not having that data has and why it would be important for you to have it?
I think not having that data means that we don't have the full understanding of what the need is in the community, what is currently being met and what the gap is in terms of what isn't being met. I think without that visibility of what's happening across the system, we can commission services that might meet a specific need but don't necessarily integrate as well as they could with the other services.
And it's also about measuring impact as well. Yeah, sorry.
No, I was just about to say we hear lots of issues about integration. Why do you know why it was the case that it wasn't extended to PHNs as well? Was there a barrier or a challenge, or it just wasn't extended to it?
I don't have information on why it wasn't.
In general, data sharing across all our, mental health, all our the health areas that we work on is certainly a challenge. It's one of the recommendations from the New South Wales Health and PHN Statewide Steering Committee, one of the 3 key recommendations, and we have a statement of commitment. And the emphasis of that statement of commitment is a one health system mindset. We know we are 2 health systems, but how do we have a one health system mindset? And part of that, 4 parts that came out of that was around data sharing. It's definitely something that we need to look at, and particularly when it comes to our joint regional mental health plans. Because if we're not being able to, how do we do joint planning if we can't share data and look at that really thoroughly, and then also evaluate evaluate the outcomes as well. It might be things like ED data, hospital admission data, those sorts of things. So how do we share that confidentially? I think sometimes it just gets a bit too hard, really.
Yeah, look, I'm particularly interested in, and I know what you've mentioned is a nice segue to the second recommendation, which refers to, the joint annual data asset assessment, which you state would be beneficial. What data sharing currently occurs between yourselves, say, and the LHD?
Currently, each PHN and LHD work their own data sharing out. We have data sharing agreements between the local health district and PHN where we can, and probably most would have some level of that. They can vary in terms of, the scope of them. It would be, one of our recommendations is actually looking at that at a statewide level. And what role can New South Wales Health play there to support that data sharing? Because it is harder for LHDs to navigate that. What can they share, what can't they? So it would be really nice to have New South Wales Health really look at those data sharing agreements and have an agreed set of data, an agreed protocol for how we do better share data.
Thanks. In terms of the data items in your submission, it talks about agreed up-to-date data items to be shared between governments and commissioning organisations. What would those data items be specifically that you're interested in?
I think, as Liz mentioned, it would include hospitalisation rates. We do have agreements between LHDs and PHNs at the moment around suicide data, but that's provided in a very specific way and not necessarily available for forward planning. So
you're looking backwards all the time. There's no forward planning component to the data. It's just this has happened. Yeah.
And I guess limits on how we can use that data as well.
Okay. Is it captured anywhere within the data about circumstances that may lead to an increased proportion of a certain population experience a certain mental illness, or numbers of say first responders in an area, or people that have potentially served in the armed forces or are current veterans? Is that captured anywhere?
Not to my knowledge, and I think what we'd need to do as part of this is actually sit down and agree what data sets do we want, what are the key things as well, because it can be really ad hoc depending on an initiative that LHD and PHN might be working on together. Whereas I think there's some really key elements that we could all agree on, and yes, there might be differences there. But yeah, to my knowledge, I'm not aware that that's captured.
Interesting.
Some is available through census data, which is primarily what we use. But again, that's not necessarily in date because
there's quite a delay. So if it were the case that you say New South Wales Health was to create a sort of standardised data sharing arrangement between the LHDs and the PHNs, could that be realistically rolled out? Or is it the case that within each LHD that the data they collect looks different or maybe called something different?
I think my understanding is that there's consistency in the data that is collected amongst those LHDs, yeah.
Well, that's a good start. I'm interested in now, just I suppose, with the Chair's permission, learning more about some of this commissioning work that you do locally and whether there is any barriers and issues to that occurring. We've heard earlier evidence today from Headspace about, and you're obviously a key commissioner to the local Headspace of funding and services. What are the current issues that exist with that work of commissioning, and is it always the case that the need is able to be met, the need that the PHN identifies is able to be met by the person commissioning the services?
I think one of the challenges, of course, with both PHNs, LHD and any organisation who receives funds is that those funds are tied to quite specific, parameters. So we certainly do in each PHN have quite a comprehensive and broad needs assessment, and what we do is either advocate for or look at how we can secure funding to meet those needs. So there are times where, yes, there's definitely a lot more need than what we have funding to do, or the flexibility of funding to do, I might say too, because Headspace funding is very specific for Headspace rollout, and so there might be another area of need in that community that we may not be able to address. But when it comes to, I think, working with the LHD, so from the New South Wales Health perspective, I think we've seen more and more LHDs and PHNs trying to work together to commission better over the last probably couple of years. And the bilateral mental health and suicide prevention bilateral agreement will start to embed that. I think it's ambitious, and the practicalities of how we commission together need to be worked through. But we're certainly seeing that that's a really a good step in the right direction. One of the challenges, though, is the capacity and the investment of New South Wales Health in LHDs to be able to do that. And often this falls on a clinician running, a mental health unit, the director of mental health, to be turning up to planning meetings. Of course, we need it's really essential that we're getting people with decision making. But when it comes to what makes the front pages, when it comes to what the KPIs have to be worked on, they're usually not planning. They're usually a lot of, not much accountability back for local health districts back to the ministry. And so what drops off? It's what's not being measured. It's what the KPIs aren't being, it's what's not receiving attention. And I think that's the biggest barrier at the moment, is there's so much goodwill, but there's really no investment of resources or accountability for PHNs and LHDs to do this. And I think the disadvantage of that is that in the long term, that's going to be the thing that means that New South Wales Health will be able to reduce their investment because we're working together. So it's that bit of pain, maybe it's one position in each LHD, I don't know, but it's that bit of pain to enable that to happen, because it's really difficult on top of everyone's everyday work, that will have these great long-term effects where we can have one integrated health system rather than duplication in some areas and gaps in others because we're not working together.
Thanks, Chair.
Thanks. I had a question around your recommendation number 8, which was the development of an integrated triage and referral process across primary healthcare and LHD community mental health services. I know that many LHDs already have mental health access lines that we've received evidence about their varying quality. I was interested in understanding, I suppose, what are the barriers to that having already happened?
This is a bit near and dear to my heart. Because a couple of years ago, primary health networks received funding to establish in New South Wales a statewide mental health line, and that in July last year, I think, went national. So there's a 1-800 number that anyone can ring to be able to be directed to mental health care. At the time, we worked with New South Wales Health around this, and there is a little pilot going on about, we've got the assessment that we do in the primary care space that people can ring, be directed, and they have an assessment. It's called a initial assessment and referral process. So we have clinicians that answer that phone and can do that assessment. And basically where that stops, sort of the higher end of acuity for that 1-800 number, is almost where the Ministry of Health or the New South Wales Health line starts. And so we've got two lines. And consumers don't know, where do I fit? Am I on the lower end outside of hospital, or do I need hospital? So what we, they're both, I think, great. The thing I love about having this 1-800 number or this head-to-health sort of concept is that it really shouldn't be up to someone who's in mental distress to decide and know where they need to go. And even for GPs and healthcare professionals, it's difficult for them as well. So it's great having this backed by a really thorough directory of all the services in a region. But the challenge is, once we get up to that higher end, to be sort of saying, oh, now actually you need to go to the other line. We need to look at a way that we can integrate both those much better, and so that they work together. We have tried in our local region, certainly we've got relationships to try and do that, but I think proper looking at that and a proper analysis and options of how we can better integrate those lines is really important.
Thanks. Any last questions? It's all right. I suppose with the last 4 minutes that we've got, I suppose I'll give you the opportunity to make any closing remarks or draw attention to any other parts of your submission that we haven't raised today.
I think we haven't spoken to child mental health yet, and we do see that as a particular gap in primary health networks, and I know that there have been a number of other submissions around it as well. So there is that initiative to create 4 child head-to-health centres across New South Wales, but really that is a need that is in all PHN and local health district regions. And I think the challenges for parents trying to navigate the system are, similar to, or even, harder than for other kind of adults around navigating their mental health care because of that paucity of child mental health services, that arbitrary division between, what is a mental health issue versus a neurodevelopmental issue, the lack of paediatric specialist workforce, and really the broader kind of service sector there being there for children.
When you talk about that, Mr. Parsons, in the submissions you've identified that Headspace services are designed for youth aged from 12 to 25 years. So in terms of the child mental health services that you're meaning, are you meaning people specifically 12 and under?
Yes, yeah, that's right.
It's currently a gap in that Headspace won't see them.
Yeah, that's correct.
Thank you.
Thanks.
Thanks so much for the time that you've taken both to come and give evidence today and also preparing the very detailed submission. The Secretariat will be in contact with you about any of those questions on notice.
Great.
Thank you very much. Thank you very much.
All these different types of missing middles.
welcome to our next witnesses from the Australian Paramedics Association, New South Wales. Thank you so much for coming to give evidence today. And noting that we've got Mr. Andrew on the WebEx as well. Could you each please state your name and position title and then swear either the oath or the affirmation?
Jessica Whittaker, paramedic, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Brett Simpson, intensive care paramedic and station officer, president of the APA New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Jeffrey Andrew, paramedic and APA delegate. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Would you like to start by making an opening statement?
Yep. Good morning and thank you for having us as paramedics to give evidence at this inquiry. My name is Jessica Whittaker and I'm a P1 paramedic at Dapto Station. I've been a paramedic for 14 years and worked in the City of Sydney, the Riverina, the Illawarra and occasionally in the Shellhaven. Also giving evidence today is Brett Simpson, who's an intensive care paramedic at Paddington, and Jeff Andrew, who's an ICP, ECP, critical care paramedic from the Bankstown helicopter base. We have all had many years of experience responding to people who are experiencing mental health crisis in the community. In some ways, these can be easy jobs for us because there are limited options for us to treat. However, the cycle of simply offering transport to an emergency department where these patients often don't get the help they need in a timely manner or leave before they're seen is causing harm. I work in an area that MAHAP operates. When this program works, it has been a game changer for us. This referral pathway has been a huge success story in the way we care for mental health patients in the Illawarra. The best parts about it for me are being able to learn from qualified mental health workers in the way they interact with people having a crisis, being able to do follow-up visits the following day for patients who can be left at home, the option of doing virtual consults for low acuity or well-known patients, and being able to phone MAHAP team before we get to a job and they can take a look at a file and let us know any red flags and give us advice on how to handle a situation if they can't attend in person or a job is not suitable for them. The downfall for this program is that it has extremely limited hours of operation from 2 p.m. till 10 p.m. The staff are amazing but often seem run off their feet, and if the jobs aren't close to where they're located, it can be a long time to wait for them to attend. MAHAP has shown that we can do better with treating mental health patients in the community and avoiding the emergency department, where there are often issues with patients becoming stressed due to the process and subsequently needing security. The biggest impact for me is the frustration that people who should be seen in the community and referred on for appropriate care are needing to utilise an emergency resource to transport them to hospital. We know that they are doing this because there is no other option for them in a difficult time. It just feels so unnecessary, but we keep doing it over and over again because we are so limited in the other services we can direct them to safely. It adds to their trauma, creates a risk for staff and other patients in the ED, and uses a lot of resources in security when things escalate. Another issue is the lack of training for paramedics having to deal with mental health patients. It's all on the job because if we have formal training, it's usually to learn practical skills. This has been one of the best things about MAHAP, as the mental health officers are so generous with sharing their knowledge and experience with us. We hope the committee looks at some of the key recommendations in the Australian Paramedics Association New South Wales submission, as these were formed after extensive consultation with our members. These include to invest in community and primary mental health care, evaluation and expand New South Wales ambulance health programs, including MAHAT and MAHAP, to cover regional areas and provide longer coverage hours in areas of high population density, and to provide paramedics with better and more regular mental health training. Thank you.
Thank you very much. We'll now go to questions from the committee. I just had a couple of my own. I was going to ask about the MAHAP program, but I think you've outlined that in your opening statement. And I also had a question about the MHAT program. There's a lot of acronyms. So I understand the MHAT program was the one that's operating in Western Sydney. and in your submission, you talked about the role of the paramedic in that team, and particularly the need to have a more senior trained paramedic. I was hoping you could speak to that and explain that for the committee.
Yeah, so previously we've had teams where we've had experienced paramedics operating in response vehicles one-on-one with usually a clinical nurse consultant from an affiliated mental health network, whether I'm aware of one from Cumberland and then in the inner city as well. And they would respond typically to mental health patients and mental health calls, people in crisis or people experiencing exacerbations of their chronic health conditions. Those programs, those paramedics and those clinicians had wildly high success rates in diverting patients away from emergency. I would suggest particularly because it had the input of not only a first responder being the paramedic component, but then also the mental health practitioner, whether it be the CNC or similar, from within the LHD or the mental health network. It effectively broke down the barriers between having New South Wales Ambulance siloed away from the rest of New South Wales Health and brought the ability to access records, treatment plans and all that type of thing together, and really provided a substantial and continuation of care for a lot of what are chronic mental health conditions in the community.
And what was the experience of the paramedics who worked in that program? Did they feel safe? Did they enjoy working there?
Yeah, I think because as Jess alluded to, the amount of mental health training we get is minimal. So being able to share in the expertise and the knowledge of those CNCs or mental health nurses was a huge boost for us, because then those paramedic practitioners would go back to their stations and share with their colleagues and other junior officers, these are the resources that we had, this was a technique that we used and it was really great. And because they were able to build a rapport with a lot of those patients, I think it was really beneficial. And I'm sure you probably had similar experience with your MHAP down in...
Yeah, I mean, we don't have paramedics, like we don't have ECPs or anything working with them. We haven't been part of that trial. But I mean, it just makes sense, doesn't it? Like, because you need to rule out medical causes and make sure that it's not something else that's causing this that needs to be treated in an emergency department. So, yeah, it just makes sense to free up that ambulance resource and just pair them up with someone with clinical knowledge.
Thank you. My next question is probably better suited to ask New South Wales Health, and I will, but given the wild success of that MHAP trial and the MHAP trial, why haven't they been done elsewhere, do you think?
I don't know.
I could only provide anecdotal evidence, and I would suggest it's probably more due to funding being diverted to other streams and just purely resource-based as well. They are wildly successful programs, so it's definitely part of our submissions and recommendations that those programs do get expanded across as many parts of New South Wales as possible, because they were just so wildly successful in being able to provide that level of care to the community.
Yeah. Thanks. I also wanted to ask about some of the, I suppose, legal issues. I know paramedics are commonly involved in sectioning people under the Mental Health Act, and you've provided quite a lot of detail in your written submission about the complexity of the various protocols that exist, and I know one issue is just the resourcing that people need, the training and the time to do this. But I suppose in your opinion, that framework of the protocols that exist in the provisions under the Act, legally, is that working, or what's the experience of paramedics working within that legal framework?
I would suggest, as always, more training is definitely required. You could put 10 paramedics in front of you, give them the same scenario and ask them what they thought their legal responsibilities under the Act would be, or what their options were in that scenario, and it's likely you could possibly get 10 different answers. In my role as a manager, it's my job to review all of the section paperwork that comes from my team, and quite often it's my job to go in and ask for more detail. Why did you feel it was necessary to section this patient, or under what concerns in your understanding of the legislation did you do that? And often it requires more training for them and for me to come in and then say, well, I think you probably could have taken this option, or it might not have been appropriate in this instance. So again, I think it's a real lack of training, and especially with a much junior workforce coming through, with recent staffing enhancements, we're recruiting and we have a much junior workforce that just simply don't have the practical hands-on experience that, seasoned officers like Jess and myself might otherwise have. So again, it just comes back to as much training as we can get. We know that paramedics are starved for it and we're always hungry for it. So as much as we can get is beneficial.
Thanks. Might go to Ms. Savell.
Thanks, Chair. Thanks to you for appearing today, and to Mr. Andrews, obviously online. With the inquiry, after obviously we've proceeded through the hearings that we will hold, we will then go about the process of drafting, obviously, the report with the recommendations to the government. And I suppose an important process of doing that is weighing up the evidence, because there's some evidence which has been very complimentary and some that's been, I suppose, conflicting. And so it's important to have, the appropriate weighting placed on various parts of the evidence. In terms of your own workforce, which I note that you mentioned you've had the extensive consultation with members, which is very, very well appreciated. How many members do you have, financial members do you have in New South Wales at the APA New South Wales branch?
The exact number I would have to take on notice, because obviously it fluctuates, but it's approaching, I'd say it's just over 2,500.
Just over 2,500. And do you have an idea of the total workforce figure? It's a question, again, I could ask New South Wales Health, but...
I would have to take that on notice. I think we get information on that sort of once every 12 months or so, and I think we're due to get that figure shortly. I'd have to take that on notice, I'm sorry.
Okay, and presumably it would fluctuate within that time. Your submission sort of details, a raft of recommendations from your own members, and one that I found interesting was around the resourcing in local hospitals more generally, for more staff in rural and regional hospitals. Can you talk me through a bit more about why in particular that was of interest to your members?
I would suggest the feedback that I've gotten personally from members, rural and regional New South Wales, as we know, struggles with general physical health and providing equity of services, and I think that is exacerbated more so with mental health conditions. I would use the example of, let's say, Moree, up in the top of the New England. Their closest dedicated mental health facility is Tamworth. So for our members up in that part of New South Wales, if they were to have, say, a sectioned patient that they would need to have further mental health care, they would possibly get immediate workup at Moree Hospital, but then they would then be transferred down to Tamworth. It might be away from support networks, family, friends. They might not have the resources to then have family come down to support them, say in Tamworth, which would be their referral hospital. And then it takes the resources for New South Wales Ambulance out of Moree, because the return trip for that type of transfer is approximately 6 to 7 hours. So it's really resource intensive to have to do those transfers, because we don't have, things like mental health services that they might be more appropriately used in certain areas like Moree. That's just one example. I don't know, Jess, if you've got more experience working in regional.
I guess the issue with those transfers, like you're tying up to security guards, you're often sedating people for this. Like it's really inappropriate and awful that we have to do that to people. So, bringing them the care in the community and possibly even avoiding them being in the ED in the first place is the goal.
Yeah, absolutely. Thank you. Thanks.
Yeah. Thank you for being here, and thank you for including the voices of other paramedics in your submission. I think it's tremendous. It makes the points very well. Can I just take you back to training? In the initial training that people receive before they become paramedics, how much training is there about dealing with mental health issues?
So I've been in paramedic for 15 years. My first face-to-face mental health training was in my initial 8-week induction back in 2009. The amount of physical face-to-face mental health training I've received since then, I would suggest would probably equate to maybe 6 to 7 hours worth, which was part of a paramedic-focused mental health and well-being training session where we also were taught or updated on things like de-escalation techniques and that type of thing.
Yeah.
I know that there is some online training that's recently been released by New South Wales Health and New South Wales Ambulance around psychological first aid and that type of thing. But again, it does have sort of an internal staff focused attribute to it. But yeah, I mean, Jess, I'm not sure if you're aware of more you've done, but apart from your initial training, it is minimal.
Yeah, and it's mostly like the training I can recall is like the mechanics, like using restraints, doing an online course for administration of droperidol, the legalities of a Section 20. Like, not a lot of it is like trying to avoid those things, and you working with so many people over the years, you can just see how much of a difference it makes, like how good you are at diverting people and talking them down and doing those sorts of things and avoiding all that in the first place.
I mean, how many of those skills can be taught, and how many, I suppose, have to be observed and practiced?
It's not so much of a science; it's more an art. And we were having the discussion beforehand. My initial interaction, I still remember it clear as day. My first interaction with a suicidal patient 15 years ago, and I was terrified. I was terrified for me. I was terrified for the patient. I was worried I would slip up, say the wrong thing. Luckily, I had my very experienced mentor with me, and she guided me through that process. And it is very much on-the-job, face-to-face training. You know, we can put out as many online, you know, webinars or quizzes that we can do online to learn these things, but it is invaluable to be able to work with another mental health practitioner, whether it be a senior paramedic or a nurse specialist or a doctor. Any type of ability that we have to have that face-to-face training is priceless. And if it wasn't for my mentors that I had as a baby paramedic, you know, the stress that must be on our junior workforce now is immense. So it's crucial.
Jump in. Mr. Andrew had his hand up.
Oh, sorry.
Please jump in if you'd like.
Probably most has been covered in those discussions, but I guess the last major update that I recall was around sectioning when that was first introduced, obviously around the legalities there. Probably I came from a nursing background, so I had the benefit of starting ambulance with plenty of experience in emergency departments. And I think probably the key, if we're looking at paramedics working with mental health, is that ruling out organic causes and differential diagnosis. And I heard the discussion previously around extended care paramedics and the specialty that is working closely in differential diagnosis, clinical examination, and I am getting a bit of feedback, sorry, so it's distracting me a little bit. But yeah, I think the key is they have to be well aligned together. We probably need some practical training, and as my colleagues suggested, that works really well, having time with other mental health team members. And I think if we're going to have these out of hospital teams, it's really important to be very specific to the things we're looking for within the mental health presentations, so that we're looking for both clinical and particularly for first-time presentations. And I think that's the bit that is lacking at this stage.
Thank you. Thank you. I'm just curious, it's not, I suppose, directly relevant to our inquiry, but do you have, as paramedics, sufficient access to vicarious trauma counselling so you can manage your own mental health?
Yeah, there has been a lot of improvement in that space for frontline staff, being able to access a variety of counsellors and staff psychologists on staff with New South Wales Ambulance. So definitely for our staff, we have seen huge improvements in support in that regard. Yeah,
that's very important. Yeah, and look, just a last question on a different topic. If I can take you to page 10 of your submission, where you talk about inadequacy of referral pathways. What would a good referral pathway look like?
So I'll use the example, my station at Paddington, inner Sydney, probably one of the busiest ambulance stations in the state, with a high workload of mental health. We straddle 3 different LHDs, Sydney, Sydney South Eastern and St Vincent's, with fragmented pre-hospital referral pathways, to the point where it's so varied, so different, it's near impossible for our frontline staff to find an appropriate referral for these patients. So that's our first barrier. The second barrier is a lot of these...
So can I just stop you there?
Yes, please.
So that's a significant barrier in the middle of Sydney.
Yes.
Anybody have any comments about the difficulty of referrals in a regional area, whether it's the same, whether it's lower, higher, any differences?
I haven't worked rural for 10 years, but when I was there was none. It was basically the emergency department or nothing. I can't speak to what's there now. Yeah, and I guess it would be varied depending on how big the town is, whether there's probably, what health services they have.
I could probably relate.
Thank you.
Central Coast is my home location, and I have worked there in both hospital and pre-hospital settings. I think the benefit of regional areas can be quite strong with the networking, and the local teams will generally know the client and have a relationship with them. And I think this is the key with the opposing to emergency services workers in uniform, police, and a very acute response. So the things that I've seen go well is where we have had those teams involved early, rather than have to convey someone to an emergency department where it's very busy, highly stimulating, and there's no anchor point for them to someone they know or appreciates. We know that mental health conditions are very diverse. We can't box people in. It's very based on their trauma experience and backgrounds. And if we can get any way of tapping in to that local resource that already know them, I've found that that's the key to things going well. I think in Sydney, the local health districts are very, it can be which street you're in as to which local health district you end up going to, and I think it makes it very complicated to refer. So I guess going back to regional areas, I think the community care can be quite good, but it's then if they do need to be outpatients, we know that there can be the long transfers away from home, away from country, and things that aren't a benefit to someone who's already under stress.
Okay, thank you.
I wanted to ask about extended care paramedics. In your written submission, you talk about some of the benefits for non-transport because of the extra skill of ECPs, and an obvious example out of the submission might be being able to suture and do wound care for someone who may have self-harmed. I was very interested to read that there are more ECPs than funded positions in New South Wales Ambulance. We've heard so much evidence in this inquiry about the workforce issues, and that for a number of other types of professionals there are just staggering vacancies that New South Wales Health is unable to fill. So I'm very interested that this is a workforce that's actually more available than the number of positions. What conversations have you had with New South Wales Ambulance about this, or what reasons have you been given for the underutilisation of that workforce?
I'll make a comment and then I'll hand over to Jeff about the skill set and the expertise that the ECPs bring. The Extended Care Paramedic Program in New South Wales Ambulance is designed specifically to keep people out of hospital, out of emergency department. They have a phenomenal skill set and a phenomenal amount of training to be able to identify complex medical histories, treat complex conditions, all in patients' homes or wherever we might encounter them. However, the program is quite poorly managed and very poorly structured within New South Wales Ambulance. I can provide, out of session, we can certainly provide some more feedback on that because I'm aware of time. But again, a lot of our positions are in Sydney. There's a few in Newcastle and a few in Wollongong, and that's it. So arguably where we see the most benefit for ECPs is in regional and rural New South Wales, specifically to try and bridge the gap between health and mental health inequality access. So we would definitely like to see ECPs and other paramedic specialists, but specifically ECPs, brought out to regional New South Wales and not just in Sydney. We already have a higher range of services here in Sydney, and the ECPs are great here, but where we do see their most benefit is in regional and rural New South Wales, specifically for issues like this. I'll go to Jeff. He'll be able to fill you in on the clinical expertise of the program.
Yes, I guess the strength of the ECP program is two things. It's the training around being able to assess the patient, and really the other strength is the referral network, and where, in my experience, we saw the program work at its best again was where we had a strong referral network, and that would also be the case with our mental health professionals. I think with the workforce, there has ECPs have found that over time, working in a single module, that can, some want to rotate through the normal ambulance model as well, and I think that's often quite a healthy thing. What has happened in the past is if people moved out of the metropolitan area or somewhere where there was funded positions, they were no longer supported to continue their ECP practice. And I guess this is a bureaucratic type, funding model that is outside of my sort of scope of how to manage that. But I guess ideally is we really want to encourage that, people to move outside the funded positions and still be able to practice as an ECP, continue in the education program and build that model in various areas around the state. I'll stand by if there's any specific questions about the model or training, but I'll leave it at that for now.
Thank you. We've only got 2 minutes left, so I might open that to you in those last 2 minutes if you had any closing remarks, or if there's anything you wanted to raise out of your submission that we haven't asked about.
I think mental health resources for paramedics are exceptionally limited. Like in our submissions, tens of thousands of presentations for mental health cases and conditions are brought to emergency departments by ambulance paramedics because we simply have no other options. We know that these emergency departments, the staff in them are highly skilled, highly professional, but the physical environments themselves are just so hostile to these people. And when they are made to wait for sometimes hours, and I've seen even patients waiting for days for treatment and referral out of an emergency department to either a dedicated mental health facility, a community outreach program, or community care services, it is just heartbreaking because unfortunately these patients become regular contact points for us. They are well known to us in our communities, and we do see their general physical and mental health decline as we see the systems put in place, unfortunately, fail them repeatedly. Being able to consolidate resources for frontline paramedics, referral networks, so that we don't have to take these people to an emergency department where we know it will more often than not exacerbate their condition, is crucial if we're going to, as we are at the most pointy end of mental health treatment in New South Wales, be able to provide more substantial and more appropriate levels of care to these quite vulnerable people.
Thank you. Thank you again for the time you've taken to give evidence today, for your written submission, and also for all of you for the work that you're doing every day in our communities. It's really appreciated.
Thank you.
The
Thank you very
Secretariat
much.
will be in touch with you about any questions on notice.
Thank you.
Thank you.
Thanks everyone for listening today in the gallery or online. It concludes today's hearing.